Hello everyone. In this section we will talk about the lining epithelium. Well, we are doing the histology in two parts. In this we are just talking about the lining epithelium of all the important system. And what I've seen is that usually people when they learn the lining epithelium, they just make a table or they make a flow chart for the lining epithelium and just keep mugging them up. In fact, it is important to understand that what is the basics behind the different type of epithelium, the structures and the functions of those epithelium, and then based on that knowledge we can understand that what kind of epithelium is apt in those certain places. So we will first talk about the types of epithelium, the classification of the epithelium, and then we will discuss it all system wise. So let's get started. So first, before we start with the epithelium, we need to know the difference between the epithelium and epithelioid. Now when you say epithelium, obviously it is the cell layer which is covering the outer body surface, or it is covering the internal organ, or it may be forming a part of the gland also. You can see it in the thyroid gland, we have a lining, or any other gland. So lining of any structure, whether it is outside or inside, that is what you call as epithelium. Now how epithelium is different from this epithelioid? Now when you say epithelioid, I'm sure you must have heard of this epithelioid in pathology also. But that epithelioid is the aggregation of that macrophage in response to some particular cell injury or certain kind of tumors. So that's a different epithelioid. In normal histology, the epithelioid actually means those cells which have the appositional surface, which have the basement membrane is also present, like the epithelium, but they do not have free surface. If a cell surface is not present, if we don't have a free cell surface, then that cluster of cell is called as epithelioid. So epithelium and epithelioid, the main difference is that epithelioid, they do not have a free cell surface. The cells from where the epithelioids are derived from, that is immature cells, they may have a free surface, but when they mature and they become epithelioid, they do not have the free surface. Now there are some good examples for the epithelioid, and it's again a potential question to be asked in the exam, and they've already asked this question once. Now the examples of the epithelioid are, now one is the interstitial cells of the Leydig in testis, the lutein cells in the ovary, the islet of Langerhans. All these are the epithelioids. We do not have the free surface for these cells. Also anterior pituitary and adrenal gland parenchyma. Along with that, even sebaceous gland, also reticuloepithelial, or also called as epithelio-reticular cells of the thymus, or you can say the ER cells of the thymus. So these are the examples. These are very, very important example, and you should remember all of them. The intestinal cells of the Leydig, lutein cells, Langerhans, adrenal gland, parenchyma, the anterior lobe of the pituitary, the ER cells of the thymus, and the sebaceous gland. Now just a small mnemonic which may help you to remember these. Like the seal and just 1, 2, 3. When you say seal, I've written 1, 2 and 3 below E, A and L. The S here will remind you of sebaceous gland. S is for the sebaceous gland. We said E and 1 is written below it. So 1 is with the E, alphabet E. What is that? That is epithelio-reticular cells. A and 2 is written below A. So we have 2 with the A. 1 is the adrenal gland, and we have anterior lobe of the pituitary. And L3, below L it is 3. We have 3L over there. Leydig, lutein, Langerhans. So these are the examples of the epithelioids, and very limited example we have, and it's not difficult to remember them. Now coming to the classification of the epithelium, after understanding the difference between the epithelium and epithelioid, epithelium is classified based on the two main factors, and those two factors are the number of cell layers and also the shape of the cell, the number of the cell layer and the shape of the cell. Like based on the shape of the cell, we have squamous and cuboidal and columnar cells, and based on the layers, we say stratified, pseudostratified, all that. So we have two types of epithelium based on these two factors. One is a simple epithelium, and then we also have the stratified epithelium is also there. Now in the simple epithelium, as we all know, we have these main three types, the squamous, the cuboidal and columnar. The squamous cells obviously are the one which are having the basement membrane, and you see the flattened cell with the round or the flat nuclei. So they are basically present at those places where the exchange has to take place between the two different environments. Cuboidal cells, on the other hand, their length and width are more or less the same, and the nuclei is present in the center. The round and central nucleus is there in that case. So we have more or less all the walls are of equal size, and we have a central round nucleus in the cuboidal cell, the typical cuboidal cells. Columnar cells, on the other hand, their length and width are not proportionate. You obviously have the more length than the width. They are called as columnar. And please note that the nuclei are oval, they are basal, but they are not touching the basement membrane. So please understand that they are present basally in the cell, but they are not touching the basement membrane. That kind of nuclei we see in a typical columnar epithelium. So that's a simple cuboidal and the columnar type of epithelium. Now from the simple epithelium, let's move on to the stratified epithelium. Well, as the name suggests, the stratified, there are stratification, the layers are present there. And the nomenclature of the stratified epithelium, it is based on the topmost layer. Now, no matter what kind of cells are present in the bottom or in between, but you need to look at what is the top layer over there. So it's a top layer which decides the name of the epithelium. Like, look at this example here. Now you're looking at this one very nice slide is there, and you can see all these cells beautifully arranged. And we have all kind of polyhedral cells in the middle. But by the time you reach the top, now you see that we have the squamous cells present over there. And that's why we call it the stratified squamous epithelium. The top layer is squamous, so we call it stratified squamous epithelium. Now this one is non-keratinized. We also have a stratified squamous keratinized epithelium. We'll discuss that separately in the integumentary system. So I want you to try for these two examples. Now look at these two guys. And could you tell me that what kind of stratified epitheliums are these? Now once again you need to look at the top layer. Now the top layer here, in the one above, you can see the top layer is made up of cuboidal cells. So obviously that is called as what? Stratified cuboidal. No matter the basal cell is cuboidal, you may have columnar in case of some ducts, we'll see that. Whereas look at this example here, in which the basal layer looks like cuboidal, then we have some polyhedral cells in between, but by the time we reach the top, it's columnar. So we call it stratified columnar type of epithelium. They usually are present in the duct system, the stratified cuboidal and stratified columnar. So that's how we name the stratified epithelium based on the top layer. After stratified epithelium, let's now talk about a special category in the epithelium, and those two special categories are, number one, we have epithelium called as pseudo-stratified ciliated or non-ciliated columnar epithelium. Now when you say pseudo-stratified columnar, that means the true stratification is not there. We do not have a multiple layer of the cell, but they look like that we have a multiple layer. All the cells are resting on the basement membrane. Now you can see all the cells are resting on the basement membrane, but because some cells are squeezed in between and some are reaching the top, so the nuclear level is different. Now see another example in the real-time section. Now you can see the nuclear level is different in all that image. We can see some goblet cells also, just ignore that for a while. But these variant level of the nucleus is the one based on which we call them the pseudo-stratified columnar epithelium. They are actually a simple epithelium, but because they look like having a layer, so we call it pseudo-stratified columnar epithelium. Another special category in this is the transitional epithelium, or also called as a urothelium. Very important, the urothelium, we will discuss them in the lower urinary tract. Now urothelium or transitional epithelium is again having multiple layers, maybe starting with the basal layer of the cuboidal cells, and then we have some polygonal cells in between. But again, when you reach the top, look at the topmost layer, guys. The topmost layer is made up of the kind of cells which are umbrella shaped, dome shaped. That's why we call them umbrella, because it is covering more than two cells, or more than 2 to 3 cells they are covering it underneath them. So we call them umbrella shaped cells which are on the top. And that's why we call them, that is called as the urothelium or the transitional epithelium. The special characteristic of the transitional epithelium, we'll talk about them separately in the urinary structures histology. The problem here is, it is not difficult to differentiate the urothelium from the other stratified squamous or other stratified epithelium, but when it is in the relaxed state. Now let's look at these two examples. You're looking at the urothelium only, but in the picture above, you're looking at the urothelium which is relaxed. So the top layer, which is the dome shape, we have these caps which are formed over them. They will help you to identify it is a urothelium only. The only problem comes when you are looking at the picture of a stretched urothelium. So when you look at the stretched urothelium, the upper layer, look at this, it looks flat. It looks like squamous only. So you got to be a bit careful about differentiating between the stratified squamous and the stretched urothelium, because they look more or less the same. Although probably it won't be a difficulty, because when you look at the stratified squamous epithelium, the number of the polyhedral cells in between, between the basal layer and the top layer, are way more than the transitional epithelium here. So that could be one way to identify that. But when you look at the stretched urothelium, it can create a confusion sometime that whether it is uro or is it a stratified squamous epithelium. So next we will talk about the endothelium and the mesothelium. While talking about the epithelium, we all heard of these two terms as well, the endothelium and the meso. The endothelium is obviously the lining epithelium which is present inside the blood vessels or inside the lymphatic vessels. That is the term used for the endothelium here. But when you say the word mesothelium, the mesothelium is the squamous layer which you will see covering all those closed cavities, like the peritoneal cavity or the pleural cavity. So that epithelium is called as is given a special name, and that is called as a mesothelium. Now, be it endothelium or mesothelium, they are all the simple squamous epithelium only. The question here is, mesothelium and endothelium are simple squamous. Now, one exception is there, and that exception is seen in some lymphatic tissue where their post-capillary venules, they are having the cuboidal cells, and we call them high endothelial venules. So in case of some post-capillary venules of certain lymphatic tissues, like in case of spleen only, so you have these high endothelial venules which are not squamous, they are cuboidal in shape, You can see in this image here. Now, you're looking at a section through that, it's a magnified picture of a venule, and what you see there, that the cells which are lining the wall of the venule, they are not squamous, they are cuboidal. And how you identified they are cuboidal? By looking at the round nucleus. So they have a round central nucleus rather than having a flattened nuclei, which is a typical feature of any venule anywhere, except in case of the post-capillary venules in certain lymphatics, which are cuboidal. So that again can be a question, that in which kind of endothelium the lining epithelium is not squamous, and that is high endothelial venules. So this is some basics about the kind of epithelium, the simple and the stratified one, and how the cells will look like, how their nuclei are present, and some basic features to differentiate them. So now let's apply them and try to understand the lining epithelium of the three major systems. We'll start with the GIT, then respiratory, and then we'll also talk about the urinary system as well. So let us start with the GIT first. So we'll be discussing the lining epithelium of the GI tract in three parts. So in the part one, let us first start with the oral mucosa. Now, oral mucosa is basically of three types. In the three types, we have a masticatory mucosa, then we have a lining mucosa, and then we also have the specialized mucosa, which is obviously about the specialized epithelium of the tongue. Now, when you say this masticatory mucosa, we are talking about the mucosa of the gingiva and also of the hard palate. The gingiva and the hard palate, and the type of epithelium present over there is stratified squamous keratinized epithelium. It is a keratinized stratified squamous. It is keratinized or parakeratinized type of epithelium. Now, please understand one thing. Anything in the oral cavity, be it gingiva, hard or soft palate, the tongue, tonsil, whatever it is, the epithelium has to be stratified squamous, because this area is subjected to a lot of friction. And wherever we have more friction, be it the oral cavity or the vestibule of the nasal cavity, the vocal cord, the terminal anal canal, the terminal the urethra, you have stratified squamous epithelium. But we still need to know that what kind of stratified squamous. Is it keratinized or non-keratinized? So in the masticatory mucosa, we have this keratinized stratified squamous. But when you talk about the lining mucosa, lips, cheek, soft palate, inferior surface of tongue, all these lining mucosa inside the oral cavity, that is having the stratified squamous but non-keratinized. It's a non-keratinized stratified squamous epithelium. Except one exception is there in the lining mucosa, and that is the vermilion border of the lip. If you look at this vermilion border of the lip, this is having the again stratified squamous only, but that is keratinized stratified squamous epithelium. So remember that exception in the lining mucosa. And when you say specialized mucosa, obviously we are talking about the dorsum of the tongue. The dorsum of the tongue is having again stratified squamous epithelium, and it's non-keratinized stratified squamous epithelium, with again an exception there, and that exception is filiform papillae. In case of filiform papillae, the epithelium is keratinized here. So this is about the oral mucosa, the masticatory, the lining mucosa and the specialized mucosa. All of them are having stratified squamous epithelium, but you got to remember that what are the exceptions there, where we have keratinized and where it is non-keratinized. So let's talk about the teeth. The teeth we can broadly divide into 3 layers of the teeth: the enamel, the dentine and the cementum. And because we are talking about the lining epithelium, so let us focus only on the enamel part. Now, as you can see in this picture, the enamel, the reason I want to tell you about the enamel is in the lining epithelium, because unlike bone, which are derived from the connective tissue, the enamel is actually derived from the mineralization of the epithelium only. The amyloblasts, which are columnar cells, they will undergo a process called as amylogenesis, and that will give rise to the enamel. So development wise, it is derived from the epithelium only. The enamel is derived from the lining epithelium only, which are columnar kind of lining epithelium. And as we know, this enamel is like 96 to 98%, it is made up of the calcium hydroxyapatite, and which is the hardest substance, the enamel being the hardest substance in the human body. Talking about the second part of the GIT tract lining epithelium, let us talk about the salivary gland. The 2 types of acinus that we see in the salivary gland, that is the mucous acinus and the serous acinus. Now, mucous acinus, if you look at the picture of mucous acinus, these are the columnar cells, and they have a flat and basal nuclei. As you can see in the picture, we have a flat and the basal nuclei, and then you can see lots of mucigen granules which are present in it. And when you stain them, because they have a lot of mucopolysaccharides present inside, so they do not stain well with the common dyes. So it looks like they have a clear cytoplasm when you see it in the histological section of H&E. As you can see in this image, if you look at one of the acinus here, this is a mucous acinus. Look at all these flat and basal nuclei present, and you can see the clear cytoplasm because the dye is not able to stain the mucopolysaccharides there. Whereas in case of the serous acinus, the cells are more or less triangular or pyramidal in shape. They also have a nuclei which is relatively basal in position, but that is a rounded nucleus. Unlike the mucous acinus, we have a rounded basal nucleus present in case of the serous acinus, and they stain intensely in the H&E staining, so they look very darkly stained with all these granules present in the apical region of the cell. So look at this this section in which you can see 2 or 3 the serous acinus here. Look at all these nuclei, we have a rounded nuclei there, and then look at all these granules which are present in the apical region of the cell, and unlike the mucous acinus, the cytoplasm doesn't look clean or clear in this case. Now moving on to the salivary gland ducts. Now the ducts in the salivary gland can be we can have an intercalated duct, we can have the striated duct, and we can also have the excretory duct. So the 3 kind of ducts that you will notice: the intercalated, the striated and the excretory duct. Intercalated ducts are those which starts from the acinus, the serous or mucous acinus, whatever is that begins from that acinus. That duct is the intercalated duct. Now in this picture which you are looking at the inset, you can see a very small part of the serous cell over there as well, and the rest is a duct, which is an indicative of it is starting from the acinus. And the kind of epithelium that you see in these ducts is a single layer of a simple cuboidal epithelium. A single layer of simple cuboidal epithelium will be seen in case of intercalated duct. The important one here is the striated duct. Well, as the name suggests, striated, that is because of the striations. Epithelium could be cuboidal to columnar. It could be a simple cuboidal to columnar epithelium. But the feature is, if you look at this in this picture, is the basal striations. The infolding of the basal plasma membrane will form these striations, on which you can see this arrow running here, that is the basal striations, which will push the nucleus more toward the central part. Unlike in the acinus, where the nucleus is more toward the base, in the striated duct, the nucleus is pushed more toward the central part because of all these basal infoldings of the plasma membrane. And between these infoldings, we have the mitochondria arranged longitudinally. And this arrangement of basal infolding and the mitochondria is an indication of the function which is performed by the striated duct, that is a reabsorption of the fluid and the electrolytes. So that's the feature of a striated duct. Intercalated duct, simple cuboidal. Striated duct, cuboidal or columnar usually, and that is having a striations in the base. And then comes the excretory duct. The large excretory duct like the parotid duct or Stenson's duct or Wharton's duct. In that we have a stratified epithelium, that is stratified cuboidal or stratified columnar. The smaller duct usually have stratified cuboidal epithelium. The larger duct, excretory duct, will have a stratified columnar. In this case, it is a case of a stratified columnar epithelium. And as we said, how will you identify the stratified epithelium? By looking at the top layer. Now this top layer here is a columnar cell. Look at all these elongated cells with basal oval nucleus. So that's a stratified columnar epithelium, which is usually seen in the larger ducts, parotid, Stenson's, all these ducts. Now let's talk about the GIT wall. Now histologically we can divide the wall of the gastrointestinal tract in 4 parts, that is the mucosa, the submucosa, the muscularis externa and the serosa. And as we know, the mucosa can further be divided in 3 parts. Mucosa is having the 3 layers. One is the lining epithelium, we have the lamina propria, and we also have the muscularis mucosa. And because our topic is the lining epithelium, so let us focus on the lining epithelium of the GIT wall, starting from the esophagus all the way till the anal canal. So let us start with the esophagus first. So in the esophagus, the lining epithelium is again stratified. Now continuing with the lining epithelium of the pharynx, we have a stratified squamous epithelium in case of the esophagus as well. Now obviously it is non-keratinized stratified squamous epithelium in case of human. The surface cells, they may have a keratohyalin granules, but still there is no keratinization. Now in human it is non-keratinized. In certain lower animals or you can say in some quadrupeds, you will see the keratinized stratified squamous epithelium based on their dietary activity. So in human it is non-keratinized stratified squamous epithelium. And when we move on to the stomach, the lining epithelium in the stomach will be the simple columnar epithelium. See, as I said, we need to understand the lining epithelium based on the function. When we are talking about the pharynx and the esophagus, it is just the conducting zone only. It is no absorption, no digestion is taking place in that region. But by the time the food reached into the stomach, the secretory enzymes have to come into the picture. In the intestine, the absorption will take place. And then the motility should be more in case of large intestine. And by the time we reach the anal canal, again, we are subjected to a lot of friction there. So that's how the lining epithelium will keep on changing based on the requirement. So in the stomach, we said that in the lining epithelium in the stomach is a simple columnar epithelium. These are secretory cells, the simple columnar. You can see the basal oval nuclei there. And the type of mucus they secrete which lines the surface inside. So we call them surface mucus cells, which is rich in the potassium content and the bicarbonate also. And that actually protects the lining epithelium from the acidic content of the stomach as well. So that's the lining epithelium of the esophagus, that is non-keratinized stratified squamous. And in case of stomach, it is the simple columnar epithelium, which is secreting all this surface mucus here. Well, in the small intestine, see, what is the main requirement in the small intestine? Because of the digestive purpose, the amplification of the mucosa is very much needed in the small intestine. And that amplification or that increment in the surface is done by the 3 major modifications that you will see, by the mucosa as well as submucosa. And one of them is the presence of the valve of Kerckering, that is also called as the plica circularis. Then we have the villi, which is again a big factor for increasing the surface of the small intestine. But the main factor, the main amplification is not by the plica or by the villi, it is by the apical surface of the cell bearing microvilli. So if let's say the question is asked that the amplification of the major amplification of the small intestine surface is done by what? Is it the valve of Kerckering? Is it the villi or microvilli? So answer is the microvilli. That's the main thing. And these microvilli, they will give the appearance to the tall columnar cells or the enterocyte cells of the small intestine like a striations again. So that's why we also call it the columnar cells with the striated border. So the striated border of the columnar cell, that is because of the presence of microvilli in them. The 5 types of cells which are present in the small intestine are Now, one is obviously the enterocytes, which we said having the striated border. These are the tall columnar cells, the predominant cell, and they are covered with the secretion that is glycocalyx. Well, glycocalyx is a glycoprotein, and this glycoprotein will help in the absorption of certain kind of amino acids and the sugar. That is what the glycocalyx is. Another type of cell that you will see in the small intestine is the goblet cell, the mucus secreting, the unicellular gland also we call them, that is the goblet cells. We do have Paneth cells. We'll talk more about the Paneth cells in the next section. We also have the cells that is called as enteroendocrine cells, which are found in most of the lining of the GIT. And we also have the M cells, also called as a microfold cells. And these microfold cells are present in that region where the lamina propria is holding some lymphatic nodule inside. Now, just to correlate with some other question, they asked this question that the gut-associated lymphoid tissue. Now, whether it is gut-associated or it is the respiratory-associated lymphoid tissue, whatever it is, they are all present in the lamina propria only. And in the region where it is present, that epithelium over there, that epithelium is by the cell which is called as the M cells or the microfold cells. So these are the main 5 types of cell which are present in the lining epithelium of the small intestine. Now again, a small mnemonic which may help you to remember them, that is PGMEE. Well, I'm sure that no one will forget this mnemonic, at least the postgraduate medical entrance examination. The P here will remind you of the Paneth cells, G for the goblet cells, M for the microfold cells, and the 2 E over there, one is the enteroendocrine gland and also the enterocytes. So the 5 types of cell in the lining epithelium of small intestine. So here's the schematic diagram which is showing the types of cell present in the small intestine. Now, one we said is a goblet cell. Now look at this picture and you can see this goblet cell here. It's a beautiful picture of a goblet cell where you can see the typical goblet shape with the basal elongated nuclei, and then we have this mucus filled region which is usually empty because it is washed off or it is gone in case of when we're doing the dehydration and the fixation of the slide. So that's the goblet cell. You can see loads of goblet cells present there. Like one example is this is also a goblet cell. And the second type of cell which we again can notice here are these tall columnar cells, that is the enterocytes, the tall columnar cells, and you can also appreciate their striated border. Can you see that? Those striations, that is a microvilli present on the surface. So the striated border of the tall columnar enterocyte. The goblet cells and the enterocyte here. Another important cell present in the lining epithelium of the small intestine are the Paneth cells. Now these Paneth cells are present in the base of the intestinal gland, or you can say in the valve of Kerckering. Now these cells are usually pyramidal in shape. As you can see, they are the pyramidal in shape. You can see that in the picture, in the schematic picture there, which is having a basal nucleus which is usually flattened or oval. And they have all these acidophilic granules which are present in them, which gives them a typical appearance because they stain intensely with the eosin. So acidophilic granules are present near the apex, as we said, and we have the oval and the basal nucleus. Now look at this picture here, and they are very, very easily identified, and you can separate them from other cells which are present in the intestinal glands. So you can see this nucleus, that is the nucleus which are basal here, and look at all these acidophilic granules which are present in the apical region. And these granules, these acidophilic granules, these cells are basically rich in the zinc content and also in the antibacterial enzymes like lysozymes. So they are the cells which are actually maintaining the immunity of the lining of the small intestine. So antibacterial enzymes, lysozymes, and the rich in zinc content. And this was the question even asked in the exam regarding the Paneth cell, that which of the following is a feature for the Paneth cell, that they are rich in the zinc content, and that is true. Now moving on to the large intestine, including the appendix. If you look at this, the picture, the histological section of the large intestine, the lining epithelium, how it is different from the small intestine is by the absence of the plica, the circularis, and also the absence of the villi. But what they have, which is also present in the small intestine, is the crypt of Libercoon. The crypt of Libercoon is a feature of the small intestine, and so is the feature of the large intestine as well. So basically the lining epithelium of the large intestine is just like the small intestine only, with the 2 major differences that you should remember. Number 1, absence of Paneth cells. The Paneth cells we just discussed, they are not present in case of the large intestine. And the second difference, which is quite notable from this picture only, you can see the enormous increase in the number of goblet cells. Goblet cell, we started seeing the goblet cell in the duodenum, but there are few goblet cells in the duodenum. The more you go down into the small to the large intestine, the number of goblet cells will keep on increasing. The duodenum is having goblet cell, more are present in the jejunum, then the ileum, and by the time you reach the colon, the large intestine, it looks like that we only have the goblet cells. We do have the enterocytes as well here, but it looks like that it is completely flooded with the goblet cells only. The function has changed now. The function has changed. Now we need to move the feces through the colon, and that's why we have loads of these mucus secreting goblet cells present in the distal part of the colon. Now talking about the lining epithelium of the anal canal, now we can divide the anal canal in the three zones, as you can see there. One is the colorectal zone, which is present above the pectinate line. Then in the region of the pectinate line, this is called as the ATZ, that is anal transition zone. That is the ATZ, that is anal transition zone. And the portion below that is called as a squamous zone. So we have a three part. We can divide the anal canal for the histological basis in three part. That is the colorectal, ATZ, and the squamous zone. The colorectal zone is having the lining epithelium, which is just like the lining epithelium of the colon above. So it is the simple columnar epithelium with loads of goblet cells present there. But if the question is asked on the anal transition zone, the transition zone is having the epithelium which is now not the columnar, it becomes the stratified columnar epithelium. So you can see the change now taking place when we go toward the perianal region. It was simple columnar. Now the layer have increased, it becomes stratified columnar, which is in the pectinate line region, or you can say in the ATZ region. And if you go below, that is in the squamous zone, as the name suggests, squamous zone, because we have a stratified squamous epithelium there, which is just like the epithelium of the perianal skin. Now, I couldn't resist showing this one wonderful picture that I have here. Now, look at this picture, guys. This is a picture which is showing all the three zones. Now, on my extreme right, you can see this lining epithelium is the usual epithelium of the large intestine, which is a columnar epithelium, and you can see all these goblet cells which are invading in. This here is the ATZ, the anal transition zone. Now, look at this anal transition zone. The columnar epithelium is now converting into the stratified columnar. Now, look at the top layer. That's how we identify the stratified. If you look at the top layer, they are not the flattened cells. They are the cells with the oval nuclei. And that's why it is stratified columnar epithelium in that zone, the pectinate line region. And you go more distal, which is then continuing with the perianal skin. This is a squamous zone because we have a stratified squamous epithelium. The surface cells here are having a squamous cells. So that's a picture which is showing you the junction of the colorectal region, the pectineal line, and then we have the squamous region. Here, this epithelium is stratified squamous, non-keratinized. We go more further, we go out, it becomes the keratinized stratified squamous epithelium. So that is about the lining epithelium of the gut. So let us have a quick summary of what we discussed in the lining epithelium of the GIT. We said the gingiva and the hard palate, that is the part of the masticatory mucosa, was having the stratified squamous epithelium, but that was keratinized. Then the lip, the cheek, the lower part of the tongue, soft palate, all this was again having stratified squamous epithelium, but that was non-keratinized. Dorsum of the tongue, the special epithelium, the dorsum of the tongue is also non-keratinized stratified squamous epithelium. I hope you remember those two exceptions. One was of the filiform papillae in the tongue and also the vermilion border of the lip, which is having the keratinized stratified squamous epithelium. Coming on to the duct part, intercalated duct was having a simple cuboidal epithelium, the single layer of simple cuboidal epithelium. Striated ducts, if you remember those basal striations which are pushing the nucleus in the center, those were having the cuboidal to columnar epithelium but with the basal striations. The excretory duct, the large duct, the excretory duct was having the stratified cuboidal to the stratified columnar epithelium. If we have a small excretory duct, that will be usually the stratified cuboidal. The large excretory duct like the Stenson's or the Wharton's duct, they have a stratified columnar epithelium. Then the esophagus again, the stratified squamous epithelium. Stomach, the simple columnar epithelium with the cell which is having the glycocalyx on the surface, that is. The small intestine, Stomach, again having a simple columnar epithelium. Small intestine is also having a columnar epithelium but with a striated border, right? And so is the same epithelium we have in the large intestine as well. But as we said, the number of goblet cells will keep on increasing as we go from the small toward the large intestine. And then we have the three zones which we just discussed. The colorectal zone, which is again having the same epithelium of the tall columnar cells, or just like the large intestine. The ATZ, which is having a stratified columnar epithelium. And finally, the squamous zone, which is going and meeting with the perianal skin, that is having stratified squamous epithelium. We started with stratified squamous in the beginning and we end with the stratified squamous epithelium at the end. So guys, before talking about the type of lining epithelium present in the respiratory tract, let us talk about the types of the cells which are present, the different type of cells which are present in the lining epithelium of the respiratory system. So we have mainly these 6 types of cell which are present in the lining epithelium. Now starting with, we have the main cell, that is ciliated cell, which is like pseudo-stratified ciliated columnar, or simply ciliated columnar, or maybe ciliated cuboidal cells at places. So ciliated cells. We'll talk about them separately. Then we have the goblet cells, obviously the mucus secreting cells, the goblet cells are also seen. The third type of cell that we'll see in the lining is the brush cells. Now, as you can see in the schematic picture also, the one which are shown with the blue, the brush cells, they do not have the cilia, but they have a blunt microvilli present over them, and that's why we call them the brush cells. Then we have these important cells called as the granule cells, also called as the Kulchitsky cells. That question is also asked once, the Kulchitsky cell or the granule cells. And these are the endocrine cells which are a part of a diffused neuroendocrine network. We will talk about the diffuse neuroendocrine system when we'll talk about the histology of the endocrine glands. So just remember, we got the endocrine cells there which are called as the Kulchitsky cell or the granule cell simply. Another type of cell that we have in the respiratory epithelium, that is the basal cell. Now again, you can appreciate from that picture the basal cells which are kind of squeezed at the base and they are not reaching the apex. And these basal cells are actually the stem cells which will give rise to all other kind of cells. Whatever other kind of epithelial cells we have in this lining epithelium, they're all derived from the basal cells. So they are the stem cells. And lastly, the cells which will appreciate from the terminal bronchioles and onward, they are called as the Clara cells, which secrete the surfactants and will keep the lower respiratory tract patent, will not allow it to collapse. That is the Clara cells. We'll discuss all these cells separately also when we'll see the different kind of lining. So again, a mnemonic here to remember all these type of cell. The 2B, the 2G, 2C, 222. So 2 boy, 2 girls, 2 children. That's how you can remember 2 boy, 2 girl, 2 children. What are the 2 boys here? The boys are the basal cells and the brush cells. 2G, the 2 girls, that is with goblet cells and the granule cells. And the 2C, the 2 children, the 2C are the Clara cells and the ciliated cells. So these are the mainly 6 type of cells present in the lining of the respiratory system. The 2B, 2G and the 2C type of cells. So let us talk about the lining epithelium in the different part of this respiratory tract. Now guys, the nasal mucosa, all the paranasal sinuses and the larynx, even the trachea, you can see the main bronchus, that is the one which supplies the right and the left lung. And then we have all these lower bronchus going into the different lobes of the lung. Segmental bronchus which are supplying the bronchopulmonary segment, that's how they are divided. And also the proximal part of the bronchiole, not the entire bronchiole, the proximal part of the bronchiole. All these, starting from the nasal mucosa, I said, they're all having the typical respiratory epithelium, and that is pseudo-stratified ciliated columnar epithelium. Look at this beautiful picture of the pseudo-stratified ciliated columnar epithelium, where you have all these different level of the nuclei present, which is giving a appearance of the false stratification. Obviously, cilia can also be appreciated. So as I said, I repeat again, just barring this vestibule part of the nasal cavity, which is having the stratified squamous. Then beyond that, the nasal cavity, the paranasal sinuses, the larynx, the trachea, bronchus, large bronchus, and the proximal bronchiole, they are all having the pseudo-stratified ciliated columnar epithelium. Obviously with some exceptions like vocal cord and the upper border and the lingual surface of the epiglottis. Well, vocal cord and the lingual surface of epiglottis, they are subjected to a lot of friction. And we said whenever we say the friction, the lining epithelium has to be the stratified squamous epithelium. So this is the epithelium of this respiratory tract till the proximal bronchiole. Remember these exceptions there, the vocal cord, the true vocal cord, and also the upper border and the anterior surface of epiglottis, also called as the lingual surface, also called as the oral surface of the epiglottis, where we have stratified squamous epithelium. So as we already said, in the large bronchiole, the lining, or you can say the proximal bronchiole, the lining epithelium is just like the trachea and the bronchus, which is pseudo-stratified ciliated columnar epithelium. But when you come to the terminal bronchiole is again having the ciliated cells, but these are the ciliated columnar cells. Rather than pseudo-stratified, we have a ciliated columnar. And more you go into the distal part, it becomes ciliated cuboidal type. So if the question is asked, the better answer is this ciliated cuboidal cell, which are seen in case of the small bronchiole. With no goblet cells. The goblet cells are now replaced by the Clara cells. Now what are Clara cells, guys? That is again is an important cell to be remembered. The Clara cells are doing the same function which is done by the type 2 pneumocytes in the alveolus, and that is releasing the surfactants. Clara cells, as you can appreciate in this picture, are those cells which are not having the cilia. These are the non-ciliated cells. And if you look at the apical surface of these cells, they are present like a dome. That's how we identify them. Because when you look at the usual ciliated columnar epithelium, you can see those ciliations over there, and their surface looks flat. But in case of these, the cells where you can see these arrows pointing, these are the non-ciliated cells, and they have the apical surface which is more like a dome shaped. And as I already said, what they're doing, they are secreting the surfactant, and that surfactant is keeping the distal part of this airway patent. It is preventing the collapsing of the distal airway. See, in the proximal part of the airway, we got the cartilages. We got the hyaline cartilage present in the trachea and the large bronchus. And anyways, the size of those, the proximal part of the respiratory passage is huge, and the diameter is large. So it's not easy for it to get collapsed. But when you go into the distal part, the lumen gets very narrow, and we need to have some compensation there. I mean, we do not have a cartilage there, but we need something else, and that is the surfactant which is released by the Clara cells, which is very, very important. They're forming the small population of cell in the terminal bronchiole, and they will keep on increasing when we go toward the respiratory bronchiole. So as we said, the next here is the respiratory bronchiole. The respiratory bronchioles are the one which are having the lining epithelium, which is indicative of the same terminal bronchiole. But see, that will gradually change. Terminal bronchiole is having ciliated cuboidal epithelium. So respiratory bronchiole now will have a function. It is the first part of the lung basically where you will see the gases exchange taking place. So the function of cilia is now getting over. All those keeping the impurity out and just, the beating of the cilia to flow the mucus along the lining, that part is done. Now the gases exchange has to take place. So the lining epithelium in the respiratory bronchiole will be seen varying from the simple cuboidal epithelium, from the ciliated cuboidal epithelium to the simple cuboidal epithelium. So they will lose their cilia in the distal part. The Clara cell will increase in the distal part of the respiratory bronchiole because more surfactant is required to be released in that region. So that is the lining epithelium of the large bronchiole, which is just like the large bronchus or the trachea. Small bronchioles which are having the lining epithelium of the ciliated cuboidal rather than pseudo-stratified, but the goblet cells are replaced by the Clara cells which release surfactants, and we identify them based on the dome. And then respiratory bronchiole. But I tell you, if the question is asked on the respiratory bronchiole, and let's say if you get both these options to choose from, that whether they are ciliated or non-ciliated, go with non-ciliated. The non-ciliated cuboidal epithelium, because as the name suggests, respiratory epithelium. So we need to answer the question based on the function, that is respiratory, that is the gases exchange. And that cannot be done by the ciliated cuboidal, that is done by the non-ciliated cuboidal epithelium. So finally, moving on to the alveoli is which is having the two types of cell present. We got the type 1 and the type 2 pneumocytes. We call the type 1 and type 2 pneumocytes. The type 1 pneumocytes, these are the predominant cells which is covering the surface of the alveolus, and they are the one which are taking part in the gases exchange. So the 95% of the cell population inside the alveolus, that is by the type 1 pneumocytes only. And these cells are like the usual flat cells that you see, that is the type 1. Type 2 pneumocytes, which are the mimic cells of the Clara cells, and these type 2 pneumocytes are more of a cuboidal cells, but with a microvilli. If you look at in the picture, they are covering the 5%, the remaining 5% area of the alveolus, and these are the cuboidal cells, but we have a microvilli on their surface. Look at that, and we know that they are also secreting the surfactants. So that's the type 1 and the type 2 pneumocyte that you will see in the alveolus. Now let me show you one real-time section for that. I hope you can easily appreciate the difference between the type 1 and type 2. The type 1, look at these flat cells over there. And type 2 pneumocyte, as you can see, this huge cell, the cell with a big rounded nucleus. And when you say the rounded nucleus, it is indicative of the cuboidal type of the cells which is present. So this is about the lining epithelium of the respiratory tract. So let us finally summarize the lining epithelium of the respiratory system. As we said, starting from the nasal mucosa and all the way till the proximal part of the bronchiole, the large bronchiole, we have the same epithelium, that is the pseudo-stratified ciliated columnar epithelium. In case of terminal bronchiole, we said those epithelium, they do not have a goblet cell, and the lining epithelium is more of a cuboidal. It's a ciliated cuboidal epithelium with no goblet cell. The goblet cells are replaced by the Clara cells. Respiratory bronchiole, the lining epithelium again now changed from the ciliated cuboidal to the simple cuboidal. And I said if you have to go with one, go with the non-ciliated cuboidal epithelium in that case. And finally the alveolus, which is having the type 1 and type 2 pneumocytes. And because the predominant cells are the type 1 pneumocytes, so if you have to go with one option, that obviously is a simple squamous epithelium. So that's about the summary of the respiratory system lining epithelium. So guys, in this section, let's talk about the lining epithelium of the urinary tract. Now you're looking at the picture of the nephron. So in this, let us talk about the lining epithelium of the Bowman's capsule, PCT and the DCT first. Now the lining epithelium of the parietal layer of the Bowman's capsule is the simple squamous epithelium. As you can see in this picture here. Now this is the parietal layer of the Bowman's capsule and the lining epithelium here is a simple squamous epithelium. Whereas in case of the PCT and DCT, the lining epithelium at both the side is the simple cuboidal epithelium, but the difference will be in case of the proximal convoluted tubule, the lining epithelium is simple cuboidal but with a brush border, and that makes the lumen of the PCT a bit hazy. Whereas in case of the distal convoluted tubule, the lining epithelium is again simple cuboidal epithelium, but there is no brush border. Now, as you can appreciate in this picture, if you look at the section where the PCT and DCT are marked, the diameter of the proximal convoluted tubule is way more than the DCT. The PCT are approximately, they are on average like 60 to 70 micrometer in diameter. Whereas when you compare it with the DCT, which is hardly 15 to 20 micrometer in diameter. So there is a huge difference between the size, the diameter of the PCT and DCT. But because PCT epithelium is cuboidal with a brush border, and that brush border will make the lumen very hazy. Can you all see all these lumen inside are very hazy? But look at the DCT. Again, the lining epithelium is what? It is the cuboidal only, but we do not have the brush border. So the lumen looks clean, the lumen looks larger in size as compared to the PCT. Now in this slide, let's talk about the lining epithelium of the loop of Henle. Now, first of all, we can see the loop of Henle can be divided into this thick descending limb. Then we have a thin descending limb. Then we have the thin ascending limb and we have a thick ascending limb. So that's the loop of Henle. So first let's look at the lining epithelium of the thick descending limb and the thick ascending limb. The good thing is thick descending limb is close to PCT. And thick ascending limb is close to DCT. So their lining epithelium is exact corresponding to the same only. So the thick descending limb of loop of Henle, if the question is asked, the lining epithelium is just like PCT, which is a simple cuboidal epithelium with a brush border. Whereas the thick ascending limb close to the DCT, so the lining epithelium is same as of DCT, which is a simple cuboidal epithelium, which is devoid of the brush border. Whereas when you talk about the thin segment, that is the loop of Henle, the thin segment of the loop of Henle, See, the diameter of the loop of Henle is approximately 15 micrometer, which is the same diameter for the venule. So when you look at the section of the histological section of the kidney, there are good chances of confusing the loop of Henle with the venule which are present around. If you look at the stains of the RBC inside, that could be helpful. But if, let's say, there are no RBCs to be seen inside the venule, they look more or less like the venule only. So the loop of Henle, the lining epithelium, just like venule, is also having a simple squamous epithelium with some microvilli present in that. We have a simple squamous epithelium. And look at this picture. If you look at this picture, now these are the venules and these are the loop of Henle. So they look, if you look at the wall, they look more or less the same only, because they both are having the single layer of the squamous cells which are encircling the inside, or they're lining them. So the loop of Henle, the thin loop of Henle, if the question is asked, the lining epithelium is simple squamous with microvilli. Thick descending limb, simple cuboidal with brush border. Thick ascending limb, we have the cuboidal epithelium with no brush border in that case. And then talking about the collecting ducts, guys. The collecting ducts, if you look at the lining epithelium of collecting duct, that is again an indicative of the lining epithelium of the portion which is just proximal to it. That is DCT. DCT was having a simple cuboidal epithelium, and so the collecting duct will be. But the way we'll differentiate the lining epithelium of the collecting duct from the DCT is by looking at the sharp and the defined margins of those cuboidal cells, which is not seen in case of the distal or the proximal convolute tubule. Now you can see this is one section, a wonderful section from the collecting duct. And if you look at these cuboidal cells, you can see a very, very clear margin of these cuboidal cells, which is certainly not seen in this section. This is one PCT you're looking at here nearby. And look at all these hazy lumen inside, and even the cuboidal cells which you can identify based on the nuclei, but the margin between the cell is not clear, which is very clear in case of the collecting duct. So let's say if you get a section, histological section of the kidney, and you have a confusion between whether you're looking at the DCT or a collecting duct, because both are having the same type of epithelium, make sure you look at that which of them is having the clear cell margin, and that will help you identify that which one is a collecting duct. Also, collecting duct in the most distal part, like close to the pyramid of the kidney, those are called as duct of Bellini. And those duct of Bellini, the lining epithelium is the same epithelium that we have here, that is the cuboidal epithelium. So duct of Bellini, which is the most distal part of the collecting duct, which is close to the, or you can say near to the apex of the pyramid, the lining epithelium is same, that is the cuboidal epithelium. Now the rest of the urinary tract passage, which consists of this minor calyx, the major calyx, the renal papillae, then we have this ureter, the urinary bladder, and even the proximal part of the urethra, that is the prostatic urethra. And then we have this membranous urethra, penile urethra, and then the terminal urethra. So starting all the way from the minor calyx till the proximal urethra, or you can say the prostatic urethra, all this portion is having the lining epithelium, which is a typical lining epithelium of the urinary tract, that is a transitional epithelium or the urothelium. So this portion is having a transitional epithelium or urothelium. We already discussed the transitional epithelium, which is having the top layer made up of these umbrella shaped cells or the dome shaped cells, which may be binucleated at some certain places. Then starting from this membranous urethra, the membranous urethra and this penile urethra, the lining epithelium is more indicative of the lining epithelium of the genital tract. And that lining epithelium is pseudo-stratified ciliated columnar epithelium. So guys, the membranous urethra and the penile urethra, the lining epithelium is pseudo-stratified ciliated columnar epithelium, which, as I said, because the ejaculatory ducts are opening in, so beyond that the lining epithelium is more indicative of the lining epithelium of the genital system rather than the urinary epithelium. And then finally the terminal urethra. When every time you talk about anything terminal, the terminal part of anal canal, the terminal urethra, the lining epithelium is again what? That is the squamous epithelium. So it's the stratified squamous epithelium which is seen in case of the terminal urethra. So that is the lining epithelium of the urinary tract. And finally, let's conclude this part by looking at the summary of the lining epithelium of the urinary tract as well. So starting again with the Bowman's capsule, we said the parietal layer was having the simple squamous epithelium. Then we have the PCT and the thick descending limb, which was having the same epithelium of the simple cuboidal epithelium with a brush border. The loop of Henle, the thin part, that was having a simple squamous epithelium, which we said we need to differentiate them with the venule, the simple squamous epithelium with the microvilli. We have the thick ascending limb and the DCT, and also the collecting duct. Again, they have the same kind of epithelium, that is the cuboidal epithelium, but this time it is not brush border. Although in the collecting duct you may have a columnar epithelium at places, but usually it is cuboidal only. Then moving on from the minor calyx till the prostatic urethra, it is all transitional epithelium. Everything in between, it is having all transitional epithelium. Membranous and spongy urethra is pseudo-stratified ciliated columnar. And finally, the terminal urethra is having the stratified squamous epithelium. So this is about the important lining epithelium of the three major system. I hope you find these videos helpful, and if you do, make sure you leave the comment after the video. Thank you. So guys, in this section, we will be covering up some important endocrine glands. I'll be starting my discussion with the pituitary gland here, especially the anterior pituitary. We'll talk about the thyroid gland, and then we'll also come to the pancreas. So starting off our discussion with this pituitary gland. Now this is a picture that you're looking at is for the anterior pituitary. In the anterior pituitary, you can see these mainly the two types of cell which are present inside. Now all these, look at all these pinkish red cells which are there. These are the acidophils. You can see all these pinkish red large cells. These are the acidophil cells, and they have a rounded cell with a rounded nucleus which is more or less central in position. So this is the rounded nucleus. As you can see, it's just a large view of what you're seeing there. So that is an acidophil, and you can see there's a rounded red cell, a pinkish cell with the rounded nucleus. These acidophil cells, as we know, they secrete the mammotrophs and the somatotrophs. They secrete the somatotroph and the mammotroph. The other type of cell that we'll see here in the anterior pituitary, these are the one which are purplish, or you can say they're bluish purple, and these are the basophil cells. So basophil cells, they are not rounded like the acidophils. They are more of a polyhedral cells. As you can see, these are more of a polyhedral cells, very darkly stained when you compare them with the acidophils. And these basophils, from the secretion point of view, they secrete the gonadotroph, corticotroph, and the thyrotroph. The corticotroph, thyrotroph, and gonadotroph, they are secreted by these polyhedral cells, which are basophil cells. So that is just an anterior pituitary. You're looking at the mainly two types of cell, that is the acidophils and the basophils. These are the chromophobes you're looking at here. The second slide which I'm showing you here is a slide for the thyroid gland. Now if you look at the picture of the thyroid gland, what you will see that these are the thyroid follicles. These are all our thyroid follicles, which are on average almost 0.9 millimeter in diameter. That's an average size of these thyroid follicle. And if you notice the thyroid follicle, the type of lining epithelium in the thyroid follicle is a cuboidal cell epithelium. Active thyroid we actually are talking about here. So we have a cuboidal cells there. And this colloid which is present inside, that is a thyroglobulin which is present inside, it is having these border which are serrated border or called as a scalloped borders, which is again an identifying feature of the active thyroid gland, having the cuboidal cells and the scalloped border which is by the thyroglobulin, which is secreted in the center of in the acinus. Another important feature of the thyroid gland are these pale staining cells which are present here. These are called as parafollicular cells. Well, they are para to the follicle, so we call them parafollicular cells. And they are, as I said, they're large, they're pale staining, and they have a granular cytoplasm. The parafollicular cells, these are the C cells or the parafollicular C cells, which, if you remember, they're derived from the neural crest cells, and they have this granular cytoplasm. They're pale staining large cells. Cuboidal cells and scallop border, as we said, these two are the features of an active thyroid. If the question is asked on the active thyroid follicle, you will see the lining epithelium inside is the cuboidal cells, and they have this thyroglobulin border. The colloid inside is a serrated border or the scallop border. But when you compare it with the inactive thyroid follicle will have a lining of the squamous. They have a squamous type of lining, as you can see here, and we have this large amount of acidophilic colloid present inside, and you will not see this serrated border or the scallop border as we saw in the active thyroid. So active is having the cuboidal cells along with the scallop borders. Inactive follicles are having the squamous cell type of lining along with the large amount of acidophilic colloid present inside and no scalloped border. That is the thyroid gland, active and inactive. Third and the last in this series, now we go on to the slide of the pancreas. Well, this slide is very much confused with the kidney at time. The reason is because the islet of pancreas inside, they sometimes give an appearance of the Bowman's capsule. So just be careful when you look at the slide of the kidney and the pancreas. These are the two slides which need to be differentiated from each other. Moreover, if you don't look at this portion, that is the islet, now this slide can be very much confused with the parotid gland also because of these acinus. So you have to make sure that you identify the slide of pancreas and differentiate this slide from the parotid gland and from the slide of a kidney. What you see in the pancreatic slide, hi guys, here you will see the acinus. Now the acinus, these acinus are having the rounded nucleus which are present in it, and they have a basophilic. You can see the color over there. They are the basophilic cytoplasm present, which is predominantly toward the basal side. Its cytoplasm is basophilic, but it's more basophilic toward the basal side of the cell. And we do have the zymogen granules present in the apical region of these cells. The one very important feature of the pancreas, which will help you separate it from the serous acinus, that in the serous acinus you will only see the lining outside, which is again having a rounded nuclear basophilic cytoplasm, but you will not see any cell in between. Look at this, guys. This is one feature here, that if you see inside the acinus, can you see those pale staining cells in between? Now those pale staining cells in between are called as a centroacinar cells. This is one most important feature which will help you separate this slide from the slide of a serous gland or parotid gland, you can say. That is centroacinar cells. This lightly stained region which I have marked here, this lightly stained region is the islet of pancreas. And this islet of pancreas, which is predominantly present in the tail part, is also pale staining. That, as I said, because of this islet only, we might confuse this slide at times with the Bowman's capsule, although they both look very different from each other. But in a low magnification, that confusion may arise between the kidney and the pancreas. So we'll see those features of the kidney separately in the urogenital part. So this is the islet of Langerhans. And as I said, they're present mostly in the tail part and having a pale staining region. In the islet of Langerhans, if you look at the cells, arrangement of the cells which are present toward the central part, they are mainly the beta cells. The 2/3 of the population, almost 75% of the cells, 3/4 of the cell I would say, it is by the beta cells only which are present in the central part. Whereas the alpha cells and the delta cells are present in the peripheral part of the islet of Langerhans, out of which delta cells are the least, which only accounts for 6 to 8% of the total cells. So that is just an overview of the islet of Langerhans. We will not be able to differentiate between the beta cells, alpha and delta cell in normal H&E staining, but just know that beta cells are present more toward the center, and these are the main cells of the islet, and alpha and the delta cells are situated toward the peripheral part of the islet of Langerhans. So this is a short discussion on these three important slides: the thyroid, anterior pituitary, and the pancreas. Hello everyone. In this section, we will be talking about the histology. Well, we already have discussed the lining epithelium for most of the organs in the body, and that I still very strongly believe is probably one of the most important part to be done. So when you're preparing the histology part, especially for the PGME examination, don't end up giving too much time to that, because we need to revise those that stuff also. So one of my suggestion to you is that your primary target in the histology should be the lining epithelium, because that's where you can expect the maximum question from. And then general histology is also very important, guys, especially the types of cartilages and the types of the glands, and also the lymphoid. That is probably the most important. Yes, we'll be discussing the systemic histology also. I'll tell you some important and the cardinal features of the genitourinary system, and also for the GIT, and also for the other part as well. But as I said, histology, it's a vast area. You cannot go into the electron microscopy of everything, although there were some recent question in which the electron microscopy was asked. So I believe that you need to restrict yourself when it comes to certain part in the anatomy, and histology is one of them. What I would suggest, that the way I've prepared these slides for you, I'm gonna put all these slides into the reference folder, into the reference section of the app, so you don't have to write anything. Histology is something, when you revise it, you want those images in front of you. You cannot just write everything about histology. It will be very difficult to read it that way, because we want those sections to be seen, those features of the slide to be seen. And it's not easy to draw a complete histological picture, and it's very much time consuming as well. So what I'm going to do is, I'm going to discuss all these slides with you. I'll remove myself from the frame so that I'll not be hiding any of your view. And later on, in the reference section, you can find whatever slides I'm going to show it to you. They're all labeled and present in that part. You can download it from there. So let's get started. And as I said, I'll remove myself from the frame so that you can have a better view of the structures in there. There we go. So guys, in the histology, as I said, first we'll begin with some more of a general histology here. I'll start with the types of the collagen fibers first. Now, when I say types of collagen fibers, there are so many types of collagen fibers we have. We don't have to remember all of them. Like type 1, type 2, type 3, 4, and 7. These are the most important, and these are the one from where you can expect a question from. Like type 1, as you can see in the slide, it is the most abundant type of the collagen fiber. And it is the type 1 which you'll see mainly in the dentine, in the tendon. And especially remember the tendon part, from where the question again can be asked. I've highlighted those in the red, which are important for the exam point of view. So skin, tendon, bone, dentine, these are the places where you'll find this most abundant type of type 1 collagen fiber. Type 2 collagen fiber, which again we'll discuss when we'll talk about the cartilages. It is the one which is abundantly present in the cartilages. So cartilage is the main site for the type 2 collagen fiber, and also in the vitreous of the eye, as you can see. Type 3, the reticulin or the reticular fibers. When you say, well, whatever structures are having this reticular formation, reticular fibers, that is the one where we have this type 3 fibers, like muscle, liver. The parenchyma of all these are made up of the type 3 or reticulin type of the collagen fibers. Type 4, again important. Type 4 is important and is asked in the exam as well, because type 4 is present in the basement membrane. So all basement membrane, they have this type 4 collagen fiber, which again is important to be remembered. And type 7, that is the one which is present abundant in the epithelia. Epithelia is having this type 7 collagen fiber. So these are the one which I feel that you should remember out of the loads and loads of collagen fibers that we have. Remember at least these 5 and some important examples where they are present. Moving on, let's now go on to some important junctional complexes between the cell. Now this also is a question which was recently asked in the exam. Now when you say junctional complexes between the cell, like what you can see here, you can see the 2 cells here which I'm pointing out here. And you can see some junctions which are present between the cells. Not only the junctions are present between the cells, there is a junction between the cell and the basement membrane as well. Let me point out these junctions and then we'll have a bit more detailed discussion in that. Like first what you see here, that this is the junction which is present, or the junctional complex present in the apical part of the cell. This is called as a zona occludens or the tight junction. Here's a bit magnified view of that. That is a zona occludens or the tight junction part of the cell. It is seen in the apical region. The one that you see in the middle part is called as the adherens, that is zona adherens. The zona adherens is the one which you see in here in the middle part here. If I just show a bit more magnified picture of that, we'll discuss them schematically in the next slide. So this is called as a zona adherens. And the one which again you can appreciate in this picture, look at this portion which is below here, which looks like a welding, that looks like a spot weld, that is called as the desmosome. It is also called as a spot weld or the desmosome. That is a desmosome. Here we go. So this first picture is just to see that where these main complexes are seen and how to recognize them. I mean, how they look like if you get this electron microscopic image. First job is to identify it. Talking more about these junctional complexes, well, let me use the schematic picture for this. That will be a bit easier for us to understand. Now, if you look at this schematic picture, we said, look at the number 1, guys, which is present close to the apical region of the cell. That one is called as a tight junction or the zona occludens. The one that you see here, which is holding on all these actin filament, the number 2 here is a zona adherens. The number 3, which I showed you in the picture, which is a spot weld or the desmosome. This is desmosome here. And these two, which were not clearly seen in the image that I showed you, but yeah, these are also there. The one which is present close to the basal part of the cell, this number 4 here, that is called as a gap junction. And if you see the cell which is adherent to the basement membrane, by this is called as a hemidesmosome. If you look at this desmosome, it looks like a half of a desmosome connecting the cell to the basement membrane. We call it hemidesmosome. That is a hemidesmosome. Starting with tight junction, as I already said, they are present in the apical region, and you will see the tight junction present where you don't want the leakage to take place between the cells. Like intestinal mucosa is there, or the renal tubule is there, even the choroid plexus, between the Sertoli cells forming the blood testis barrier. So all these are the regions where you see the tight junctions, the apical region present, and you can see this is some examples where you'll find the tight junctions. Zona adherens, which you see next, zona adherens, which if you look at the picture, they are actually joining these actin bundles. They're joining the actin bundles with each other, and the connecting protein here is cadherin. That is important to remember. The cadherin is the connecting protein here. The same goes with the desmosome. In the desmosome also they contains cadherin. They are having the cadherin here. As I told you, they are called as a spot weld. And what they are connecting for the neighboring cell, they are connecting the intermediate filament. If you see here, they're connecting the actin filament, and they are connecting the intermediate filament of the neighboring cells. Example in the skin. So spot welds anchors the intermediate filament in the neighboring cells, and that is again it contains a cadherin. That is important thing to remember, that cadherin is the one which is contained in the zona adherens as well as desmosome. Coming to gap junction, guys, gap junction in which connections are the unit. I mean, gap junction is made up of usually the 6 subunit, and that is called as a connections. It is also called as a cell-to-cell junction, and that allows the ions to move from one cell to another cell. Even the water-soluble ions and the molecules which can move from one cell to another cell, and that is only possible through the gap junction. Another question important here is that what is the unit for the gap junction? That is called as a connection. It is usually made up of 6 subunits, and we call it connection, which is a gap, which is the connecting protein here. And then coming to the hemidesmosome. Well, you already saw it in the desmosome. They are connecting the intermediate filament. Well, here also hemidesmosome is connecting this again intermediate filament of the cell, but this time to what? To the basement membrane or to the basal lamina. But the main difference here is that when we saw the desmosome, we said they contain cadherins. But here they are connecting the intermediate filament to what? To the basal lamina, to the basement membrane, and they do not contain cadherin, they contain integrins. Their connecting protein is the integrin. So this is about the junctional complexes where we have the tight junction, zona adherens, desmosome, gap junction, and hemidesmosome. And these are the some important features that you should remember on which the questions might be asked. In this second part, guys, we will talk about the muscles, that is cardiac muscle and the skeletal muscle. We'll compare some important histological features of the two. And we'll also talk about the cartilages, another important histology which in the exams can be asked about the differences between the hyaline, elastic and the fibrocartilage. So once again, I'll go the same way. Let me just go out of the frame. Okay, what you see here, that this is a picture of a skeletal muscle. Well, how can I say it is a picture of a skeletal muscle? First of all, the few things to be noticed here. Now look at these bundles, guys. These are the bundles which are cylindrical and they are unbranched. In the cardiac muscle, you will see them branched, but here they are unbranched. That is one thing. Secondly, these cardiac muscles are multinucleated and their nuclei are present on the periphery. So that you can see there's a multinucleated and they have a peripheral and a flat nuclei, which again is contrary to the cardiac myocyte, where you'll see the more of a oval nucleus. So we have flat and peripheral nuclei in case of the skeletal muscle. Cross striations are present in the cardiac muscle also, but very, very prominent cross striations are seen in the skeletal muscle. You can see all those cross striations which are called as the A band and the I band, that is dark band and the light band. Where I'm sure you know A band here means that is anisotropic band and I is the isotropic band which is forming these cross striations. So when you look at the picture of a cardiac muscle, you need to notice that we have the unbranched bundles, the nuclei are present on the periphery and they're flat. Then we have these cross striations which are representing the A band and the I band, that is dark and the light band. Whereas if I compare it with the cardiac muscle, now what you see in the cardiac muscle, the first thing to note in the cardiac muscle is that there are cross striations present in this also. If you can appreciate some striations in that, there are some cross striations in this as well, but these cross striations are not as prominent as they were in case of the skeletal muscle. Secondly, the nuclei, if you see here, nuclei, they are not on the periphery, they are centrally placed nuclei and they are oval. In the skeletal muscle, they were flat and peripheral. Here they have centrally placed oval nucleus in case of the cardiac muscle. Another feature which separates them from the skeletal muscle is that they have a branched and anastomosing bundles. If you look at, there was a parallel bundles in the skeletal muscle and they were unbranched. But you can see all these branching. That is very much which can be very well appreciated in this picture also. You can see all these branching are present there. So I have a branching and anastomotic bundle here. And the one main feature of the cardiac muscle is the presence of all these intercalated disc, which is a functional syncytium here. That is intercalated disc. If I tell you a bit more about the intercalated disc, a question asked on the intercalated disc is that what type of junctional complexes are present in the intercalated disc. So let's say this one schematic picture here showing you that. Now we have fascia adherens, the presence of fascia adherens. Fascia adherens is just like the zona adherens we discussed. Fascia adherens is present in the non-epithelial tissue. So obviously we're talking about the cardiac muscle, so that's a non-epithelial tissue. So we have fascia adherens here. They're also connecting the actin filaments of both sides. Then we also have the desmosomes. And in the horizontal part of the syncytium, you will also see the gap junction. And guys, these are the gap junctions. This is the main thing. The gap junctions are the one which are responsible for making it a functional syncytium by making the electron coupling between the neighboring myocyte, cardiac myocyte, that forms the functional syncytium. So this is the cardiac muscle having a less prominent cross striations are there, which are there, but they're very less prominent compared to the skeletal muscle. Branched and anastomosing bundles are there. Nuclei, unlike skeletal muscle, is central and oval. And most important to remember that what are the type of junctional complexes you see between the two cardiac myocyte. That is, we have a fascia adherens and we also have a desmosome along with gap junction. That was about the cardiac muscle. Now moving on to the cartilages. We said the three type of cartilages were discussed, and this again is an important part. Now first we start with this picture here, guys. This is a picture of a hyaline cartilage.
Yeah, this is a picture of a hyaline cartilage. Well, how come it's a hyaline cartilage? First of all, look at the perichondrium part. Now, what you see here in the perichondrium region, that we have an outer layer which is actually fibrous, and the inner layer, this one is a chondrogenic layer, or you can say cellular layer. So you can see the outer fibrous layer and the inner cellular layer, which is the feature of a hyaline cartilage, and it is also the feature of elastic cartilage. We'll see that. We already discussed in the type of collagen fiber that in the matrix, the type of collagen fiber you will see here is mainly the type 2 collagen fiber in case of hyaline cartilage. That is, type 2 collagen fiber will be there inside. If I focus on to this part of this hyaline cartilage, what you will see that you have these cells which are present in the bundles. These are the chondrocytes which are present in the groups. And these chondrocytes which are present in the group, they are forming something called a cell nest. That could be made up of the 2 chondrocyte, maybe 4, maybe 6. So they come together and they form this cell nest. Look at this picture which is showing you the better view here of the cell nest. You look at all these cell nests which are present here. And around the cell nest, you see the darkly stained matrix which is called as a territorial matrix. You will see it around the cell nest. That is called as a territorial matrix, which again is a feature here because in between the cell nest, you will see this lightly stained region also, which is called as the interterritorial matrix. And that will help you differentiate between the hyaline cartilage from any other cartilage, because they, first of all, they have the feature of the cell nest, where the chondrocytes which are present in lacunae are grouped together. Then we have this darkly stained matrix around them called as a territorial matrix, and the lightly stained region between the cell nest is called as an interterritorial matrix. So presence of perichondrium, territorial and interterritorial matrix, chondrocytes in lacunae, and the cell nest, that is a feature of the hyaline cartilage. Comparing this hyaline cartilage with the next one, now guys, this is a slide of a fibrocartilage. Now, what do you have in the fibrocartilage? First of all, the important feature in the fibrocartilage to be noticed, which separates it from the elastic and hyaline, that there is no perichondrium. There's no perichondrium present in the fibrocartilage. The bundle of collagen fiber here predominantly is type 1 collagen fiber. We do have type 2 as well here, but it's mainly the type 1 collagen fiber, which is a predominant collagen fiber in case of the fibrocartilage. Now, all these are the parallel bundle. Look at this. All these are the bundles of the collagen fiber that you see here, parallelly arranged. And because of these parallelly arranged collagen fiber bundles, the chondrocytes which are present inside, they are squeezed and come in a line. So that again is a very important feature of the fibrocartilage, that the chondrocytes are arranged in a row or they are arranged in a single line. That is a feature of the fibrocartilage. So absence of the perichondrium, type 1 collagen fiber, the thickly type 1 collagen fibers are there. Chondrocytes are arranged in rows. That also is unique about this fibrocartilage, which is not seen either in elastic cartilage nor in the hyaline cartilage. So guys, let's now start with the histology of the lymphoid, which I said in the beginning also, it is one of the most important area in the histology that you should know about. So in this section, we'll be discussing the 4 slides. We'll talk about the lymph node, we'll talk about the spleen, thymus, and the tonsil, and see what are the main differentiating features which are present between them, how the lymphocytes are arranged, and how will you distinguish between these 4 major slides. So let's go with the first slide here, in which you are looking at the lymph node. Now, this is a picture of this section showing the lymph node. Now, what are the features in the lymph node? That first of all, it is divided into cortex and medulla, which you will not see in case of the spleen. So we have in lymph node, we have the cortex, and the medulla will be seen, that is divided into cortex and medulla. And it is obviously capsulated. We have a capsule present around it. Now, this capsule which you see present on the surface, this capsule is also sending the extensions inside in the cortex region, especially it is dividing the cortical part, and these are called as a trabeculae. So you will see that trabeculae are long trabeculae which are present through the cortex, and they're dividing the cortical part where the lymphatic nodules are present. Deep to the capsule, and not only deep to the capsule, even deep to the trabeculae also, we have a sinus here which is called as subcapsular sinus, or which is also called as subtrabecular sinus as well. So we have a subcapsular and subtrabecular sinus which is seen deep to the capsule and also deep to this trabeculae. Lymphatic nodules. The lymphatic nodules which are predominantly having these B lymphocytes are present only in the cortex part of this lymph node, which is again a differentiating feature when you compare it with the spleen, that the lymphatic nodule present here are present, which is having mainly the B lymphocytes, are present mainly in the cortical part, are present only in the cortical part, they're present in the cortex, which is having these central part, if you see, which is lightly stained, called as a germinal center. That is a germinal center which is central part here. Well, the story about the germinal center is they are lightly stained because they have these large euchromatic lymphoblast and the plasmablast, and they keep maturing and they move toward the periphery. So when you see toward the peripheral aspect, we have more darkly stained region, but the central part, which is called as a germinal center, it is lightly stained because of the plasmablast and the lymphoblast present in that region. In the cortex, apart from the cortex, between the cortex and medulla, this region is called as a paracortex region. Look at this. This part here where I'm pointing at right now, this is called as a paracortex part. The difference is in the paracortex, we do have predominantly the T lymphocyte. B lymphocytes were where? In the lymphatic nodule, and the T lymphocytes are the one which are present in the paracortical region or the paracortex. Moving down, coming to the central part of the lymph node where we have medullary cords and medullary sinuses. If I put this picture here, which is showing a better image of the medullary cords and sinus. Well, what is medullary cord, guys? If you look at all these are the medullary cords here, which contains the mature B lymphocytes in the medullary cords. And they are present in the random clusters, so we call them the cords. Whereas then we have the endothelial line spaces inside called as the sinuses, and medullary sinuses are the spaces which drains the lymph from the cortical region. They take the lymph from the cortical region and toward the efferent part of the lymph node. So this is the region where you have the medullary cords and sinuses. So these are the features of the lymph node. As we said, we have a presence of capsule, we have a subcapsular and subtrabecular sinus. We got these lymphatic nodule which are having the B lymphocytes mainly, having a germinal center in between in the middle part, in the central part, which is having the lymphoblast and the plasmablast. They keep maturing and they move toward the periphery. You can appreciate the paracortex region, the paracortical region where the T lymphocytes are present, and then in the middle part we have the medullary cords and sinuses. We do not have lymphatic nodule in this part. We only have the medullary cords and sinuses, where the medullary cords contain the mature B lymphocytes, or you simply can say plasma cells are present in the medullary cords. Let us compare this slide with the next one, which is a bit contrary to this, and that is the slide of a spleen. So guys, here you are looking at a slide of a spleen. Now first of all, we do have a capsule in the spleen, although it is not shown in this picture because it is not taken from that region maybe. But yes, we do have the capsule. What is different here, that first of all there is no differentiated cortex or medulla. There is no differentiated cortex or medulla like in case of the lymph node. Here there is no cortex or medulla is there. As I said, capsule will be present. Capsule is giving off the extension inside, that is a trabeculae. Now you can only see some pieces of the trabeculae here. The trabeculae are branched, they are short, they are thick, they are robust. So we have very thick and branched trabeculae, and they are present throughout the spleen. It's not that they are only coming out from the capsule part. The spleen display a very unique feature of an open and as well as the closed circulation. Well, I'll explain that what is that open and closed circulation in the next upcoming part here. So they have this open and closed circulation. Both type of circulation are seen here. Just like lymph node, even spleens are having the lymphatic nodule, and they are also having the lymphatic nodule with the same principle, that the central part is a germinal center which is lightly stained, and that the peripheral part is darkly stained. That makes it quite easily identified in the section. That is, germinal center is there. Lymphatic nodules are also the feature of the spleen, but as I said, there is no cortex in medulla, so you will not see lymphatic nodule at some particular site only. You will see them dispersed in the entire section of a spleen. Well, what other important thing that you see in the lymphatic nodule, which is again a very unique to the spleen only, that if you look at these arterioles, now initially these arterioles were in the center, but with the migration of these lymphocytes toward the periphery, these arterioles, they come toward the end, or you can say they are placed now eccentrically. They are called as eccentrically placed splenic arteriole. So when you see the lymphatic nodule will be seen in the lymph node also, spleen also, and tonsil also. But in the spleen, the lymphatic nodule is having these features of the splenic arterioles present toward the periphery. They are present toward the periphery. That is again a feature of the spleen. The lymphatic nodule, because we have the WBCs present inside them, that's why the lymphatic nodule is so called as a white pulp part of the spleen. And this one is a red pulp part of the spleen here. The white pulp and the red pulp. When you say white pulp, obviously these are the lymphatic nodules which are forming the white pulp. And when you say red pulp, guys, the reason we call them red pulp, because when these blood vessels are running inside the lymphatic nodule, once they come out of the lymphatic nodule, they splay their blood into the parenchyma. So when you see the blood vessels inside the lymphatic nodule, that tells you that, okay, there is a closed circulation present. But as I said, the blood vessels, once they are out of this lymphatic nodule, they also display the open circulation, and that is why you see the the circulatory blood components are to be seen inside this region, and that's why we call it what? Red pulp. This is all the red pulp region here, which is containing the RBCs. That makes it basically red. We have neutrophils. We even have monocytes. So all these blood components will be seen in the red pulp region, and that's what I was talking about when I said the closed circulation and the open circulation. So that is a feature of a spleen. Moving on, the next slide that you're looking at, again, which is having a lymphatic nodule, and that is the slide of a palatine tonsil. Well, when you look at the slide of a palatine tonsil, always go for the lining epithelium first, because that is one thing which will help you identify this slide or help you differentiate this slide from the lymph node. Otherwise, there could be a lot of confusion. So look at the surface here, guys. We do have a lymphatic nodule here. We do have a germinal center here as well. But the important thing is, because it's a palatine tonsil, so the oral surface of the palatine tonsil is covered with this stratified squamous epithelium. Well, anything in the oral cavity or facing toward the oral cavity, they have this stratified squamous epithelium. We do have tonsillar crypts also present in the palatine tonsil, although we cannot see in this section. But tonsillar crypt again could be a good hint if you look at the picture of a tonsil. So there are tonsillar crypt which can be seen dipping inside, and again there will also be lined by the stratified squamous epithelium, because even the tonsillar crypt are facing toward what? They are facing toward the oral surface only. If you see some, the skeletal muscle in the basal part of the palatine tonsil or toward the floor part of the palatine tonsil, there's nothing to be surprised of. See, palatine tonsil, the bed of the palatine tonsil is made up of the superior constrictor muscle, which is a skeletal muscle only. So if you see some skeletal muscle present in the basal part, which is not there in this slide, so as I said, don't be surprised. I'm sure you can identify the skeletal muscle by looking at the parallel bundles, peripheral flat nuclei, cross striations, right? So if you see those muscles present toward the basal part here, that probably will be some fibers of the superior constrictor muscles you might be looking at. So that is the palatine tonsil. If I just give a quick recap what we discussed in this lymphatics slide. So in the lymph node, we said, guys, we have a capsule, we got a subcapsular and subtrabecular sinus, but the lymphatic nodules were present only where? In the cortex. In the medulla, we had medullary cords and medullary sinuses. Then we saw spleen. In the spleen, there were no cortex and medulla. We have these lymphatic nodules with germinal center present throughout the parenchyma. And it also displayed the open and the closed circulation. The closed circulation was displayed within the white pulp, and the red pulp was displaying the open circulation in case of the spleen, which also had eccentrically placed splenic arteriole, which was quite unique to the spleen. Whereas in the palatine tonsil, the lymphatic nodules are seen again with the germinal center present here. Tonsillar crypt, if you can see that, fine. I believe that if they give a picture on the palatine tonsil, they probably will give it from the tonsillar crypt part. And the most important thing to note is that lymphatic nodules, which you will see close to this stratified squamous epithelium, will be there. And lastly, moving on to the fourth and the last slide in this lymphoid part, that is the slide of thymus. Well, what you see in the thymus here, which is differentiating it from the other part, that first of all, the entire lobe is divided into certain lobules. We do not have, there is no lymphatic nodules here. There is no lymphatic nodule like the tonsil and all. We have a lobe, and the lobe is divided into small lobules. These are all lobules. Look at this pointed where I am. There is a lobule part here. And what you see in the lobule, that we have a cortex and we have a medulla. But if you see the cortex of this is darkly stained, the medulla is lightly stained. The cortex is darkly stained because in the cortex we have these large number of densely packed small lymphocytes. So loads of small lymphocytes will be present in this cortical part here. And we have these incomplete septations actually, which are dividing the cortex part, not the medulla, but you look at the cortex is divided by these incomplete septations. And that's why they say that if you look at a lobule of a thymus, we have a common medulla for many cortex. So these are all individual cortex now found because of these incomplete septations. And for all these cortex, we have this common lightly stained medulla in the middle. Well, medulla is lightly stained because of number of these pale reticular cells and less number of lymphocytes are present there. We have more number of small lymphocytes in the cortex part, but we have less number of lymphocytes in this medullary part, along with some pale staining reticular cells as well. The main feature of the thymus, one is that there is no lymphatic nodule. But when you see the medulla of the thymus, you will see a very important feature here called as a thymic corpuscle or the Hessel's corpuscle. What is this thymic or the Hessel's corpuscle, guys? If you look at the center of this Hessel's corpuscle, that is a degenerated hyaline mass that you will see here. And this degenerated hyaline mass, it is surrounded by these concentric lamellae of the reticuloepithelial cells. So you will see these dying reticuloepithelial cells which are surrounding this hyaline mass. They are actually forming the hyaline mass once they are completely degenerated and they come into the center here. So that thymic corpuscle or the Hessel's corpuscle, that again is an important feature of the slide of the thymus. So that is about the lymphatics histology, the slide of a tonsil which is differentiated based on the stratified squamous epithelium, the slide of this spleen which is having no cortex medulla. You will see the lymphatic nodule with the eccentrically placed arteriole, and the open and the closed circulation can be appreciated there. The thymus, again no lymphatic nodule in there, but the Hessel's corpuscle present in the medulla is one important feature to be remembered. And lymph node, in which the lymphatic nodule with the germinal center are present toward the peripheral part, or in the cortex only. In the medullary part, we have medullary cords and medullary sinuses. So in the image-based question of the lymphatic nodules, in this lymphatic slides, the most important thing here is to identify the section, and then only we can move ahead with the features. So this is about the histology of the lymphoid system. So guys, in this part, we will talk about the two specialized epithelium. We'll talk about the layers of the retina, which was a recently asked question in the exam. And we'll also talk about the tongue, the specialized epithelium of the tongue, which is having a taste bud, with the main focus on differentiating between the different type of papillae in the tongue. So starting with this slide here, that is a slide of the retina that you're looking at. Let's look at what are different layers we have in here. So what you see in the layers of retina, we say we have 10 layers. Now starting with the layer number 1, which is a pigment cell layer, and that is made up of mainly the cuboidal cells. This is a pigment cell layer, if you can see carefully. That is a darkly stained pigment cell layer, and that is mainly made up of the cuboidal cells. Then we have the layers of number 2 layer, that is layers of rods and cones, which is present on the Brooks membrane. So we have the layers of rods and cones, which is second layer after the pigment layer. Followed by the layers of the Muller cells, which is the external limiting membrane. We have one external limiting and one is internal limiting membrane, which will be the last one. This is the external limiting membrane that we're looking at with the Muller cells. Followed by the outer nuclear layer. Well, as the name suggests, outer nuclear layer is the nuclei for the photoreceptors. This is the layer for the photoreceptor cells to be present. So that is called as outer nuclear layer. Followed by the outer plexiform layer. As the name suggests, plexiform layer. This is the layer, outer plexiform layer, where the rods and cones are synapsing with the bipolar cells. So you can just see those axons where they are synapting with each other, and that's why the name is plexiform. Then we have the inner nuclear layer, which is the nuclei of the bipolar cell. Well, that's what the upper layer is indicating. If upper layer is the outer plexiform layer, where the rods and cones are synapsing with the bipolar cell, so the layer below is for the bipolar cells itself. That is the inner nuclear layer. After inner nuclear layer, we have the inner plexiform layer, where you'll see these bipolar cells will be making a synaptic contact with these ganglion cells. So that is a layer called as the inner plexiform layer, and this is the layer where these bipolar cells are making a synaptic contact with these ganglion cells. Followed by these large ganglion cell layer, the ganglionic cell layer. And then these ganglionic cell layers are the one which will continue and form the axons of the ganglionic cells will continue and form the nerve fiber layer, where we have the axons of the optic nerve. So-called the axons of the optic nerve are formed by the ganglion cell layer. And lastly, one was the external limiting membrane, and now number 10th layer is called as the internal or inner limiting membrane, where you have the processes of the Muller cells. This is the layer where you have the processes of the Muller cells to be seen here. That was the external limiting membrane for the Muller cells, and this is the inner limiting membrane for the processes of the Muller cells extending till this level. So these are the 10 layers in the retina. This question, I believe, can be asked only for the identification basis. I mean, you need to identify that which layer, how it looks like, and the question, even the recent question which was asked was about the identification of one of the layer of out of these 10 layers of the retina. In the series, the second slide we will talk about also having a specialized epithelium, that is the tongue. Now, what is so special in the tongue epithelium? And when you look at this picture of the papilla of this picture, I know that one type of papilla which might be coming to the most of the people's mind. So first of all, we need to identify if you are looking at the right papilla or not. Now, first of all, guys, you do not see any conical projections from the surface. If there are no conical projection from the surface, that means it is not filiform papillae. It is not filiform papillae because there is no conical keratin projections to be seen on the surface. Now, second feature that you need to notice here, that taste buds are seen, and you can see these taste buds present inside the furrow. So this is also not the section for the fungiform papillae. This is a taste bud, you can see it in the furrow here, so it is not a fungiform papillae. And third important thing, which is the main point to note here, that if you look at this, the papillae here, the shape of the papillae is more like a quadrangular. It is not mushroom shaped. If it was a mushroom shaped papillae, then it would be circumvallate papillae, but it's not. It is not mushroom shaped. It is not umbrella shaped. So it is not circumvallate papillae either. So the section that you're looking right now is a section of the foliate papillae. This is actually a section of the foliate papillae. And what you see, just like any other part of the tongue, the lining epithelium will be the stratified squamous epithelium only, right? That is stratified squamous epithelium. And as we said, you can see these taste buds which are present in the furrow. These are the taste buds which are present in the furrow. If I just show you one enlarged image of the taste buds, you can see some sustentacular cells inside and the sensory cell are also therein. That is the taste bud, a section of the taste bud. That's how it look like. It is relatively very lightly stained compared to the lining epithelium which is on the side, and that's how we appreciate these taste buds here. What else you'll see here in this section, if you look at this region, there we have all these serous glands present, and the serous glands of the tongue which are called as the von Ebner's gland. These are the von Ebner's gland or the serous gland, and these you can see, look at this, these are duct of the von Ebner's gland which is also seen opening inside the furrow here. So these are the glands, and that is a duct of the von Ebner's gland. Deep to the epithelium of the tongue, you can appreciate these skeletal muscles also. So in the basal part, below the epithelium, you can also notice this skeletal muscle. I already know how to identify the skeletal muscle, but tongue is having so many skeletal muscles, so that can also be appreciated deep to this epithelium and the von Ebner's gland as well. So this is the two slides which we talked about. The slide of the retina, in which, as I said, the main thing is to identify the layers, the 10 layers. And this is a slide for the tongue, in which the first job is to see that what papillae is not here. I mean, it's not filiform, fungiform or the circumvallate papillae. It's a section of the foliate papillae with almost the same features. If you will see it more like mushroom shaped, then you would have called it the circumvallate papillae, where the taste buds are present inside the furrow. So this is about the two important slides of specialized epithelium. So guys, the next section of histology that we are starting with is the histology of the respiratory system, in which we'll start with the slide of a trachea. We'll see the important features of the trachea. Because we know about the general histology, so it's all about just putting those things together. Putting the hyaline cartilage with the lining epithelium, with the smooth muscle, and then some seromucous glands. So all that arrangement to be seen, and what differences will be seen between the slide of a trachea, intrapulmonary bronchus, terminal bronchiole, respiratory bronchiole, and the alveolus. So once again, if I just remove myself from this picture so that I don't hide any of this labeling. There we go. So what you're looking at right now, it's a slide of a trachea, guys. Now, what are the features in the trachea that are to be noted? Now, you see that this is a continuous band of hyaline cartilage will be seen. That is a C-shaped cartilage, as we all know, is a feature of a trachea, is to be seen here. And this hyaline cartilage is not broken into pieces. It's one continuous C-shaped or D-shaped, whatever you call it, the hyaline cartilage to be seen. And the remaining posterior part of it is, the reason it is C-shaped, because the esophagus is present behind it. If it is a complete circular cartilage, then it will be compressing the esophagus as well. Therefore, the space which is present behind is to be bridged by something smooth, and those smooth muscle which is bridging the gap here is the trachealis muscle. Look at that. That's a trachealis muscle to be seen here. So that is the hyaline cartilage. If you see the entire section of the trachea, you will see that between the two ends of this hyaline cartilage, the trachealis muscle will be seen spanning. You already know the features of hyaline cartilage, the cell nest, territorial matrix, interterritorial matrix. So I think I don't have to tell you about how to identify the hyaline cartilage. What else to be seen here? In the lamina propria, you will see some serous and some mucous glands are present here. Look at this in the more magnified view. This is the hyaline cartilage here, right? That is the hyaline cartilage. You can see these chondrocytes present in the lacunae. Here is the lamina propria part, in which you can see these some serous and the mucous gland, and these are the serous demilunes you are looking at. Well, serous demilunes are the artifact which are found during the preparation of the slide, in which the serous cells will be seen capping the mucous acinus. So we call it serous demilune. That is serous. There is nothing called a serous demilune as such in the real-time section. So while making the sections, they are formed. That is serous demilunes. And the lining epithelium. Well, it's the respiratory lining epithelium. Whether it's the larynx part or the trachea part or the larger bronchus, they all have this pseudo-stratified ciliated columnar epithelium with goblet cells. Again, I don't have to tell you much about the lining epithelium. We discussed about it in detail in the general histology in the lining epithelium section. That is, it is pseudo-stratified ciliated columnar. So as I said, the presence of the hyaline cartilage, number one, and that is a continuous band of hyaline cartilage, the C or the D shaped, you can say the hyaline cartilage is there, bridged by this smooth muscle that is trachealis, presence of pseudomucous gland, and then we have the pseudo-stratified ciliated columnar epithelium with goblet cells. That is the features of the trachea. How to differentiate the trachea from the intrapulmonary bronchus? Well, first of all, when you see the intrapulmonary bronchus, like this is the next slide you're looking at, this is the intrapulmonary bronchus. Looking at the surrounding structures, the alveolus and all, you can say, okay, this is obviously not trachea. But imagine if you're looking at only at this part here and you still have to identify it. The most important feature here is that hyaline cartilage is present in parts. It's not a continuous band of hyaline cartilage. We have hyaline cartilage present in parts in case of the intrapulmonary bronchus. So again, you can identify the hyaline cartilage, presence of perichondrium and the cell nest and everything. You know this, but you will not see it as a continuous band. You will see it present in 2 pieces, 3 or maybe more. That is in the intrapulmonary bronchus. No trachealis muscle here. Now you will see inside this cartilaginous part or hyaline cartilage region, you have a continuous band of smooth muscle which is present around here. The same, again, pseudomucous glands are located. The lining epithelium is again pseudo-stratified ciliated columnar epithelium. So these things may not help you to distinguish between the trachea and the intrapulmonary bronchus. Go for the cartilage. Till the time you keep saying the word bronchus, larger bronchus, they have hyaline cartilage. But unlike trachea, it will not be a continuous band, it will be in pieces. The third slide that I'm going to show you here, going further, is a slide of a terminal bronchiole. Now, we're coming from the bronchus to the bronchiole, guys. This is a slide of a terminal bronchiole. Now, what you see that, first of all, there are no hyaline cartilage. So once you stop looking at the hyaline cartilage, that means you're not looking at a bronchus, now you're into bronchiole. One thing, so there's no hyaline cartilage there. And we have a very, very thick continuous band of smooth muscle, and because of this continuous thick band of the smooth muscle, the lamina propria and the mucosa inside are pulled and they will form the mucosal fold. These mucosal folds are not a typical feature of the bronchus or the trachea, but that is seen in the terminal bronchiole because the smooth muscle there is the one which cause them to lie in the folding manner, and that is, these are called as the mucosal folds. Lining epithelium has also changed. If you look at this, now it is more of a simple columnar epithelium rather than pseudo-stratified ciliated columnar epithelium in case of the trachea and bronchus. So once again, it's always good to keep on comparing them. Trachea, it was pseudo-stratified epithelium with the continuous band of the hyaline cartilage, and the trachealis muscle was bridging the gap. In the intrapulmonary bronchus, more or less the same feature. The same epithelium, hyaline cartilage is also there, but hyaline cartilage was present in pieces or in parts. Terminal bronchiole, once again, we have a continuous band of smooth muscle also here, but what has changed? First of all, there is no hyaline cartilage. And number 2, the epithelium also has changed now to what? Simple columnar epithelium. Now the epithelium is more of a simple columnar epithelium, and that throws the mucosa into this fold called as mucosal folds. Now from terminal bronchiole, if we move on to the respiratory bronchiole, now again the feature would be more or less same. You will again might see the columnar epithelium, you will see the smooth muscle also. Again, there's no cartilage. But see, the important feature here is we have a discontinuous band of the smooth muscle. Can you see all these present pieces? There is smooth muscle here, here. Look at this smooth muscle here and here. So the lining epithelium is again columnar to cuboidal only. Smooth muscle is present. No hyaline cartilage, of course, but this time even smooth muscle is having a discontinuous band of the smooth muscle, and the epithelium is also discontinuous. And this discontinuity between the smooth muscle and the epithelium is giving out all these pockets. These are called as alveolar pockets or alveolar out pockets, which are leading into the alveolus. So they're leading into the alveolus part. You can see all these are the alveolus. We already discussed the lining of the alveolus in the lining epithelium, having a type 1 pneumocyte and type 2 pneumocyte which secretes surfactants. So leading from the respiratory bronchiole into the alveolus are these called as the alveolar out pockets. So let me again once give you a quick recap what we discussed in this respiratory histology. Trachea, hyaline cartilage, continuous band. C-shaped to protect the esophagus which is behind, and then the free end of that hyaline cartilage is connected by those trachealis muscle. Lining epithelium is pseudo-stratified ciliated columnar Seromucous gland will be seen with serous demileunes can be appreciated in the section. When you come, and obviously a lot of goblet cells are also there in the lining epithelium. When you compare that with the intrapulmonary bronchus, again the lining epithelium is same, pseudo-stratified ciliated columnar, smooth muscle continuous band is there. Hyaline cartilage is also present there, but hyaline cartilage is broken into pieces, or the hyaline cartilage is present in parts rather than as a continuous band. Comparing that with the terminal bronchiole, no hyaline cartilage in terminal bronchiole. Smooth muscles are having this thick bundle of smooth muscle is present around, and that is throwing the lamina propria into the fold called as a mucosal fold. And the lining epithelium also has now changed from the pseudo-stratified ciliated columnar to simple columnar epithelium. From terminal bronchiole, now we come to the respiratory bronchiole, the one you're looking at. It is having a discontinuous band of the smooth muscle and the discontinuity of the epithelium also. Otherwise, most of the features, they look like the bronchiole. And because it is a discontinuous band of the smooth muscle, so now you will not see the mucosa is thrown into fold because it is not a continuous band around it. So there is no, if you look at this picture here, there is no mucosal fold to be seen in this part here. In fact, because of this discontinuity, you see all these gaps in between, and these are called as alveolar out pockets, which are leading into the alveolus. So these are some basics of the respiratory histology you should know to differentiate between the trachea, bronchus, bronchiole, respiratory bronchiole, and the alveolus. So guys, let us now start with the histology of the GIT. I'll be discussing the number of slides with you, and as I already said earlier, you don't have to write anything in this because it's virtually impossible to draw these diagrams and then compare them later on with if a real-time section is asked in the exam. So all these slides will be made available to you. Labeled slides will be made available to you in the section of the app itself. So just listen to this part and once again just understand the differentiating features between the slides of the GIT, especially how to differentiate between the esophagus to the fundus of the stomach, to the pylorus, to the duodenum, jejunum, ileum, colon, appendix, and the liver. So let's take all these slides one by one and have a very quick discussion on the main differentiating features between all the slides in here. So starting with the slide that you're looking at right now, that is the esophagus. Well, this is a slide of the esophagus because you can see this stratified squamous epithelium which is present on the top here. Look at this very thick layer of the stratified squamous epithelium present here. So the only part of the GIT starting from esophagus and till the rectum where we have a stratified squamous epithelium is this region. You'll see the stratified squamous again in the lower part of anal canal, but this is where to start from. Along with that, if you look deep to the stratified epithelium or to the epithelium, then we have lamina propria. Well, lamina propria is the usual site for the presence of the gut-associated lymphoid tissue, which is not to be seen here. But when we'll go to the ileum and all, you will see it more prominent, the gult, or you can say the gut-associated lymphoid tissue. They even asked this question once, that this gut-associated lymphoid tissue is seen in which part of the section of the GIT. So that is a lamina propria. If you look at deep to this, guys, you can appreciate these muscles. This is muscularis mucosa, which is made up of these longitudinally arranged muscles. That's why you see them in this manner. So that is a muscularis mucosa. And then comes the main feature of the esophagus slide, and that is the esophageal gland, which is present in submucosa. Esophagus and one will be the duodenum. These are the two slides in which you will see the glands which are present inside the submucosa. Otherwise, majority of the intestinal gland or the pyloric gland or the fundic gland, they are present in the lamina propria only. But here the glands are present where? In the submucosa. That is the very, very important thing to note. And look at this, how these glands look like. If you see, these are the mucus secreting acini. These are the mucus secreting acini which are having this truncated columnar epithelium. And if you look at the nuclei is flat and basal. So we have this flat and basal nuclei, if you can follow the cursor here. and having a truncated columnar type of cell, that is the esophageal gland, mucus secreting gland. Well, we cannot appreciate very well the muscularis externa in this image. We have this very thick layer of muscularis externa. A thing about muscularis externa of the esophagus, that we have striated muscles in the upper one third. Remember that we have a striated muscles in the upper one third. We have striated and smooth muscle in the middle one third. And then we have only smooth muscle in the lower one third. I repeat again, in the upper one third. If the section is from the upper one third, we have inner circular, outer longitudinal muscle that will be there. But in the upper one third, the muscles are striated. Middle one third, striated plus smooth, both will be seen. And in the lower one third, only smooth muscle will be seen, forming the muscularis externa of the esophagus. So that is one slide of the esophagus. The two things, if I say the two most important feature to remember, one is the stratified squamous epithelium, and then the esophageal glands present in the submucosa. Well, moving on, going to the next slide, guys. The next slide here is actually the slide of the stomach, and this is the fundus of the stomach you're looking at. I'm purposefully looking at this part where you can see the gastric pit. So this is the fundus of the stomach, which is not difficult to identify. It's not difficult to identify because of the parietal and the chief cells, which gives it a very significant appearance here. Now, the lining epithelium, as I said, cannot be appreciated here, but the lining epithelium that you will see here will be the tall columnar epithelium. Whether it is a fundus of the stomach or pylorus of the stomach, this lining epithelium will be the tall columnar epithelium. What you see, this is the neck region actually, and this is the base region here. What you see in the neck region, you can see these cells. Well, these cells are the parietal cells. Look at all these eosinophilic cells. These are the parietal cells with the central nuclei. Well, the so-called parietal cells or the auxentic cells, they have a very bright acidophilic cytoplasm. They have a very, very bright acidophilic cytoplasm, and we have the central nuclei. So that they are very easy to identify if you're looking at the slide, even in the 10x. We also have these chief nucleus, chief cells which are present in the basal part here, more predominantly present in the basal part and the body part. They have a basophilic appearance, the cells are basophilic. And these chief cells are also called as a zymogenic cells, or you can even call it the peptic cells. They have a central nuclei, they have a basal, there's a basophilic granular cytoplasm will be present in them. And let me just put one picture for you, which is a enlarged view of the same. Look at this. You can see the parietal cells here, right? Very clearly you can see the large eosinophilic with bright nuclei here, that bright acidophilic cytoplasm is there. And if you look at these chief cells, first of all, they are present in cluster. You can see they are present in a cluster here. They are very, the basophilic cells, they are, you can see this blue, dark, intense blue stain. So that is, they are basophilic. And they also have a centrally placed nuclei. So these are the chief cells, also as I said, called as zymogenic cells or the peptic cells. So these are the two important features when you're looking at the slide of the stomach to identify. One is the parietal cells and the chief cells presence. But if I compare this slide of the stomach, the fundus of the stomach, to the pyloric part of the stomach, the first thing you will notice the gastric pit. Look at the gastric pit here, guys. We have a very, very deep gastric pit. Look at this, starting all the way from the surface, and they're very deep. Their deepest gastric pit will be seen in this pyloric part of the stomach, one. Secondly, what else you will notice here, that the pyloric gland, which are again present in lamina propria, just like other even intestinal gland and the stomach gland, we said they are present in the lamina propria. Pyloric gland. When you look at the pyloric gland and you look at the lining epithelium of this gastric pit, you will notice that both have columnar epithelium. This is columnar. These are also columnar. But the difference is, if you look at the gastric pit lining epithelium, the nuclei is a tail here. If you look at the nuclei, they are oval, basal nucleus, but oval in shape. But if you look at the pyloric gland nuclei, because they are again secreting mucus and the gastrin hormone. So again, just like a mucus secreting cells, they have a flat and basal nuclei. Make sure when you look at the pylorus of the stomach, look for the gastric pit, number one. And number two, make sure you differentiate between the lining of the gastric pit and these pyloric gland and gastric pit both have columnar epithelium, but pyloric gland, this columnar epithelium is having a flat and basal nuclei. They have a flat and basal nuclei which secrete mucus and some hormone like gastrin. So these are the two slides of the stomach. We saw the pyloric part and previously we saw the fundus of the stomach. Well, not difficult to differentiate between the two. Now, sometime we get confused with whether you're looking at the gastric pit or the villi. I mean, they look like a projection in this manner only. So is it like a villi or these are the gastric pit? Well, please understand one thing, that gastric pit, they all start from the surface. So you will see that all of them are starting from a one leveled surface. But when you see the villi are usually unequal in size. So if you look at the top of the cell, which is almost at one plane only, look at this entire top is at one plane. These are the gastric pit coming down from there. But the way I show you in the next slide, look at this. If you look at the slide of a small intestine, let's say there's a slide of a small intestine. Look at first of all, you can see the different heights and the gaps between the villi, which will help you in identifying or differentiating between the villi and the gastric pit here. So coming to this slide is actually of the duodenum. That's a slide of a duodenum. The duodenum, as you can see, their villi are broad villi we have in the duodenum, and they're very closely packed. Lining epithelium is also columnar here. We have a striated border, but we have this closely packed villi, which in case of the duodenum. Epithelium, as I already said, we have a columnar epithelium with striated border, and you can see few goblet cells can be appreciated. You can very easily look at these, which looks like an empty spot dots in between. These are nothing but the goblet cells. And the more you go in the distal part of the intestine, you start from the duodenum to the jejunum and to the ileum and to the colon, the number of goblet cells will keep on increasing. The number of goblet cells will keep on increasing. By the time you reach the colon, it will look like that we have all goblet cells only, nothing else is there. Now, once again, you can see very thick muscularis mucosa here. That is a muscularis mucosa. You can see this bright red here. That is muscularis mucosa. And again, as I said, the unique feature, just like the esophagus, even the duodenal gland, or also called as a mucus secreting Brunner's gland, are also present where in submucosa. So please remember that esophageal gland in the esophagus there, those are also mucus secreting glands, and these Brunner glands are also the mucus secreting glands, and both of them are present in the submucosa, unlike other part of the intestine where the glands are where? In the lamina propria part. Intestinal glands are in the lamina propria. So this is the slide of the duodenum. Moving on from the duodenum, if we go on to the next slide, the slide of the jejunum. Now, what you see in the slide of the jejunum, guys, look at this. First of all, look at this crypt of Lieberkuhn here. And if you look at the villi present on it, these villi, which are again having the same columnar epithelium with more number of goblet cells, the goblet cells are now increased. And we have more of a tongue-shaped villi of different heights. It's a tongue-shaped villi which you see, and they are of different height. We have more closely packed villi, and in case of the duodenum, they are not that closely packed in the jejunum, and they are more of a tongue-shaped villi. We call them the tongue-shaped villi. One very important cell in which the question is asked is the Penneth cells. If you look at this part, I mean, you can appreciate the Penneth cells in here, in the basal part here. The Penneth cells, which looks like columnar, or you can say pyramidal type of cells, they have their apical region which is having these acidophilic granule. Can you see it in this? You can see there is an acidophilic granule which is present in their apical part near the apex, and that is having a lysosomal activity to digest the bacterial wall. This is a function of the Penneth cells which are present here in the intestine. You will see them in the jejunum and ileum and even duodenum also, and these Penneth cells have the acidophilic granules present close to their apical region. That is the duodenum, and now it is a jejunum part. And in this slide, you can also notice this. Can you see that, guys? This here is what? That is the gut-associated lymphoid tissue that you see here. And we said, where is it present? It is present in the lamina propria. Rest of the story is same. Again, you can see inner circular muscle there and outer longitudinal muscle followed by the serosa. So these are the usual thing which we know about the slide. Now from duodenum and jejunum, if I move on to the ileum part, now what you'll see in the ileum that the number of goblet cells will suddenly increase and we have these few villi compared to the jejunum. Look at this slide. So what you see here, the number of villi are less, they are short, and again the upper surface of the villi is variable. That is always a tell for the villi that villi have an upper surface which is variable. The number of goblet cells will increase in this part. Although this section which I took it from the Defure Atlas, it is not showing a lot the goblet cells in it, but it is for sure that more you go distal part of the slide of this GIT, the number of goblet cells will keep on increasing more and more. So we'll have more number of goblet cell in ileum compared to the to the jejunum and the duodenum. And the most important thing here to be seen, guys, we said the gut associated lymphoid tissue which is present in lamina propria here, that gut associated lymphoid tissue, look at these lymphatic nodules here which are called as Pear's patches. They are even distorting the muscularis mucosa and extending into the submucosa as well. That is a very, very important feature of the slide of the ileum, that we have this loads and loads of the gut associated lymphoid tissue, and these Pear's patches, these lymphatic nodules which are present in lamina propria, they are so extensive that they are distorting the muscularis mucosa and even extending into the submucosa part as well. You can see them extending into the submucosa part. Rest again the same, the inner circular and the outer longitudinal muscle followed by the serosa. So that was the difference between the duodenum, jejunum and the ileum, the slide of the duodenum, jejunum and ileum. Now from the ileum, let's move on to the slide of a large intestine. Now let's anticipate first before I show you the slide. In the large intestine, what you will see, first of all, no villi. Villi will be absent. Intestinal glands will be there, but the villi will be absent, and the goblet cells number will be, it's huge. I mean, if you look at this slide of the large intestine, it looks like that we have nothing else apart from the goblet cells. It is like flooded with the goblet cells here. So we have an absorptive columnar epithelium on the top, that is there. No villi, it's not villi. They are on the surface only, that is absorptive columnar epithelium. And we have these loads and loads and loads of goblet cells which are present here. And we said the villi are absent. And another important feature which you will notice in this section here, that if you see this entire section of the large intestine, the outermost layer, that is the outer longitudinal muscle will have a 3 regional thickening, and they form they collect together and they form something called as a tinea coli. If you look at these 3 longitudinal bundle around the large intestine, that is called as tinea coli, which is a modification of the outer longitudinal muscle of the muscularis externa. That is in case of the large intestine. And finally, if I look at the slide of the appendix, well, in the slide of the appendix, there are very good chances that you'll be looking at the entire slide at once only. It's a very small section, so we probably will be looking at the entire thing at once. Once again, the lining epithelium is columnar, which never changed from all the way from the stomach till here. It's always the columnar epithelium. Yeah, the surface keep on changing. The striated surface is there and all. So this is the columnar epithelium with M cells, that is antigen transporting cells are there, which is the M cells will be seen in this columnar epithelium. Cannot be identified M cells in the HND staining, but yes, they're there. Lymphoid tissue again in the lamina propria. You can see there's a lymphoid tissue again in the lamina propria. And another important thing about the appendix that you'll see, that the muscularis mucosa, either you'll not see it, or if you see it, it is very poorly defined, and interrupted muscularis mucosa is to be seen in this region. You can just see some patches of smooth muscle in between. Look at this here, the one here, some smooth muscle there. So because of these lymphoid tissue, which is flooded in the appendix part also, again you will see the muscularis mucosa is distorted in this case. So this is about starting from the esophagus, duodenum, jejunum, ileum, large intestine, and now we're looking at the slide of the appendix. Well, continuing with the GIT part, let's discuss one more slide, and that slide is actually of a magnified view of the liver lobule. Now, if you look at the liver slide, now some important thing to note here, In the slide of the liver, guys, what you will see that first of all, look at all these hepatocytes which are arranged radially. And between these radially arranged hepatocytes, we have the spaces, the endothelial line spaces, which are called as the sinusoids. You can see those are the sinusoids which are marked here. These white spaces in between that you see, these are sinusoids. Here is the central vein. The direction of the blood flow will be from here. The hepatic artery and the portal vein will drain the blood into the sinusoids, and that will travel toward the central vein, and then central vein forms the hepatic vein and then goes into IVC. So this is a portal triad that you see here inside. You can see the portal vein is there, you can see hepatic artery is there, and the bile duct is also to be seen in this connective tissue part, and the direction of the blood flow is toward the central vein. Now, if you look at it in a bit low magnification, actually the three types of liver lobule you can notice. If you see the central vein, look at this. If there's a central vein here, and look at these portal triad arranged on all the side of the central vein, this is an example of a classical liver lobule. That is called as a classical liver lobule. One central vein in between, and then you see in all from all the six sides it is covered or surrounded by this portal triad, and obviously the blood will be coming toward the midline, toward the central vein only. That is a classical liver lobule. The second type, which is called as a portal lobule, if you join a line connecting the three neighboring central vein, so what you will see that a one portal triad in between, the hepatic artery, portal vein, bile duct in between, they are surrounded by the three central vein, and this type of classification, this is called as a portal lobule. The previous one was the classical liver lobule, and this one is a portal lobule. And number three, the one which is more practically used, it is also called as a functional unit of the liver. They ask this question also. Functional unit of the liver is what? That is called as liver acinus. That is liver acinus. If you connect the two central vein and the two portal triad neighboring with each other, now this in between, this is called as a liver acinus. And if I just take an enlarged view of this acinus, which you can see here, so guys, it's quite obvious that the blood will be running from the central part toward the central vein here. It will be coming from this part, that is where we have the hepatic artery and portal vein, and the blood through the sinusoids will be reaching the central vein toward the periphery. So this midline zone here is called as zone 1. That's how we classify them. Then we have zone 2 outside it, and there is a zone 3 even outer one, which is close to the central vein. And because oxygenated blood is coming from the midline and going toward the central vein, that is more toward the outside, that is why zone 1 is the one which is first to get affected by if any toxic changes takes place, because that toxin will first go into the zone 1 itself. So the first to see the alcoholic changes or toxic changes to be seen is seen in the zone 1. And because the blood is running from this point toward the central point, toward the central vein, that is why the outermost zone, that is zone 3, is the first to get affected by the hypoxic changes, because that is the last zone to get the oxygenated blood. So it is the first part to get affected by the hypoxic changes. Zone 1 first to get affected by the toxic changes, and zone 3 it is the first to get affected by the hypoxic changes. That arrangement is called as the liver acinus, and that is the functional unit of the liver on which the question is asked. So guys, this is about the histology of the GIT part, in which we saw the slide all the way from the esophagus till the appendix, and also the slide of the liver as well. So guys, in this section, let us talk about some urogenital system slides, starting with the slide of a kidney, and then ureter, bladder, and the vas deferens, epididymis, testis. So we'll be looking at some important slides there, and once again, mainly looking at their differentiating features here. So starting with the slide of a kidney, now what you see here, that if you look at the Bowman's capsule, well, this probably should not be a problem in identifying the Bowman's capsule, because of the squamous cells lining, you can identify the Bowman's capsule. I already told you this slide can be slightly confused with the slide of pancreas at times. But when you see the pancreas around it, around that islet of Langerhans, we have those serous acinus present around them. Here we have the PCT and DCT which are mainly surrounding it. And the important difference here between the PCT and the DCT, in the proximal convoluted tubule as well as distal convoluted tubule, the lining epithelium is pyramidal cells, or you can say cuboidal cells. But if you look at these pyramidal cells present in the PCT, they have these brush border, and because of the brush border, the lumens, the lumen of the PCT look quite hazy, and it looks small also. That's the main difference, because when you look at the section of the DCT, the lining epithelium is cuboidal cells, but because there is no brush border, so we have a clear lumen which looks wider also. So if you're looking at a section, if you're looking at the part where the lining epithelium is the pyramidal cell or cuboidal cell, you can say, and they have a brush border, hazy lumen, or you can say small lumen, because of that haziness, it is PCT, which is obviously a bit darkly stained. In the DCT, the cells are lightly stained, there is no brush border, and we have a clear and the large lumen to be seen in case of the DCT. So that is a PCT and DCT. If you are looking at the loop of Henle, we already discussed in the loop of Henle in the lining epithelium that what kind of lining epithelium will be there in the descending limb and the ascending limb and the thick limb and thick limb, also thin limb and thick limb also. We have done with that part in the lining epithelium. Collecting tubule. Well, again, the collecting tubule lining epithelium could be anything between through cuboidal to the columnar epithelium, and it is relatively lightly stained, so it will not be difficult to differentiate that as well. Well, we already discussed these features in the lining epithelium, so there is nothing much to discuss again here. But just make sure you differentiate between the PCT and DCT, and differentiate the slide of a kidney from the slide of the pancreas or the slide of the parotid. Continuing here into the urinary system, the next slide that you're looking at is a slide of a ureter. Well, what is important to note in the slide of a ureter or bladder or for the trigone for that matter, that this time the lining epithelium that you're looking inside is a transitional epithelium. It is a transitional epithelium. And this transitional epithelium, it is approximately 5 cell thick. We already talked about the transitional epithelium also in the lining. Then followed by the lamina propria we have, and look at this thick muscle coat. So we have just like other part, we have an inner longitudinal muscle and outer circular muscle, and because of the push of these muscles, the lumen inside is star-shaped. So that also is a feature here. We have a star-shaped lumen in the ureter, and that is because of these thick coat of the inner longitudinal and the outer circular muscle. As it's written that in the middle part and the lower part, I mean after the upper 1/3, in the middle and the lower 2/3 part of the ureter, you may see a third layer of outer longitudinal muscle as well. So if the section of the ureter is taken close to the bladder, you might see 3 layers of smooth muscle there: inner longitudinal, middle circular, and then again outer longitudinal muscle can be seen in that lower part. And when you see that slide, when you see the lower part of the ureter, which is having a 3 layer of these smooth muscle, the obvious confusion between this slide and other slide would be the slide of the urethra. Because when the slide of a ductus deferens, because the slide of a ductus deferens is also having the 3 layer. I'll just show it to you after this. So that was a kidney. Now this is a slide of a ureter. Now moving from the ureter to the bladder, urinary bladder. In the urinary bladder, the lining epithelium is, again you can see it's a transitional epithelium, but this time we have a mucosal fold that is actually empty bladder, so you can appreciate the mucosal fold of the transitional epithelium. Epithelium will be shown very clearly if they show you the section of the urinary bladder or even the section of the ureter. Unlike ureter, if you look at the smooth muscle here, which is having an obliquely placed muscle, transversely placed, as well as a longitudinal muscle as well, it's a bit difficult to distinguish between these muscle coat. So the muscle coat of the ureter was very easily distinguished, inner longitudinal, circular, and maybe outer longitudinal, but not in case of the bladder. So if you're looking at a transitional epithelium, there is no star-shaped lumen or anything like this because it's a section of a bladder. It's a big section. Mucosal fold can be appreciated, and if you see that we have a very thick muscle coat which is not very easily distinguished between the 3 different type of muscle we have here, it possibly is a slide of the urinary bladder.
Moving on, coming to the next slide, the next slide that I'm showing you is from the genital system, and that is a slide of a seminiferous tubule. If you look at this section of the seminiferous tubule, and then we'll go to the next to the epididymis and vas deferens, it's a section in which you can see one seminiferous tubule can be seen here. Well, in the seminiferous tubule, the most important cell to be noticed here are the Sertoli cells. Now look at this, the big euchromatic nuclei which you can see here. And these are the non-dividing cells. These are tall columnar cells, although they doesn't look like typical tall columnar cells because they have these appendages which are coming out. And if you look at the schematic diagram here, these are the Sertoli cells, and look at these appendages of the Sertoli cell which are connected to each other by some tight junction or zona occludens, which is forming this BTB, that is blood testis barrier. So blood testis barrier is found by the tight junction between these Sertoli cells. And because of this tight junction between the Sertoli cells, the entire seminiferous tubule is actually divided into certain compartments in which the different stages of spermatogenesis will be seen, starting from the spermatogonium to the primary spermatocyte, secondary spermatocyte, spermatids. So you can see these spermatids or the spermatozoa, which you will see present toward the lumen of the seminiferous tubule, but they're still not in the lumen of seminiferous tubule, which requires the process of spermiation to release them in the lumen. What else you will see that outside the seminiferous tubule, in between the seminiferous tubule, and that's why we call them these cells, these are the interstitial cells, or called as the interstitial cells of Leydig. These are the polyhedral acidophilic cells, if you look at that carefully, and these are the cells which actually secretes testosterone. So important cell that you need to notice inside the seminiferous tubule are the Sertoli cells, and these important cells that need to be noticed between the section of the seminiferous tubules, that is the interstitial cells of Leydig, or the Leydig cells, which are the testosterone secreting polyhedral acidophilic cells. Moving on from the seminiferous tubule and coming to the epididymis. Now look at this. This is the section of the epididymis. Now what you see in the section of epididymis, guys, the lining epithelium here is pseudo-stratified columnar epithelium. It's a very closely packed pseudo-stratified columnar epithelium with the stereocilia. We have a non-motile stereocilia which is present toward the luminal surface. And the important thing is that when you see the section of the epididymis, you will see this coat of smooth muscle running around all of them. Well, the purpose for the smooth muscle to be present around them is because these are the stereocilias. They are not, epididymis is site for the maturation of the sperm and for the storage of the sperm also. But the sperms has to be propelled out. They will be propelled out by the action of the smooth muscle which is present around these sections of epididymis, and not by the stereocilia which you see on the luminal surface of these cells. You can see these concretions in between, that is the sperms in the lumen. So pseudo-stratified ciliated columnar epithelium with stereocilia, and then we have this radially arranged, or these you can say circularly arranged smooth muscle which are propelling the sperm out of the epididymis. Epididymis, followed by the epididymis, the next slide you'll be looking at is a slide of a ductus deferens. And what you see, the first impression when you look at the slide of a ductus deferens, it gives you an impression of the slide of ureter also. It looks like irregular star-shaped lumen again. It is just like the ureter, we have a star-shaped lumen inside. But the important thing is, in the ureter, the lining epithelium was transitional, which is multi-layered, 4 to 5 layers were there. Here the epithelium is what? Again, it is pseudo-stratified ciliated columnar epithelium with stereocilia. That's the same epithelium that you saw just in the epididymis will be seen in the ductus deferens as well. And the most striking feature of the ductus deferens is the thick layer of these muscles which are present around here. If you see, we have inner longitudinal muscle followed by the middle circular muscle, and then again we have these outer longitudinal muscle, and the need for these muscle is because ductus deferens is not the site for the storage of the sperm. Sperms are stored in the epididymis. So during ejaculation, we need to have these strong smooth muscle around the ductus deferens so that they can very powerfully squeeze the ductus deferens and propel the sperm out of it and take it to the ejaculation. So for the rapid propulsion of the sperm,
and there is no storage in that, that is the purpose of having this very, very thick, smooth muscle coat around them. So you just see a small lumen in between, which is irregular star shaped, with pseudo-stratified columnar epithelium, and obviously with the stereocilia. And the important thing is the smooth muscle present around are the one which are propelling the sperm out of it. Then we have the prostate gland. The prostate gland, next slide that you're looking at is the slide of a prostate gland. In the slide of the prostate gland, what you'll see, it is also called as a fibromuscular gland. It's called as a fibromuscular gland because it is made up of the glandular acinus are there, which are lined by this simple columnar epithelium. It could be from simple columnar to pseudo-stratified columnar epithelium. So, see, first of all, please understand that why do we call it fibromuscular gland? It is a fibromuscular gland because it's not only the fibrous structure that you see in between all these acinus, you will see loads and loads of smooth muscle present there. So in most of the slides, you will see that the connective tissue is present there. We have a lamina propria and we have this connective tissue present in that. But here, what we have is the smooth muscle which you will see running around all these acinus, which are lined by the simple columnar to maybe pseudo-stratified columnar epithelium. And that's why the fibromuscular word is used here for the smooth muscle here. In the cavity, in the spaces inside the acinus, you can see all these concretions, guys. These are called as a prostatic concretions, which are also called as a corpora amylacea, which is nothing but the calcified product only which you see in the center of the acinus. So that is the slide of the prostate gland. That prostate gland, it's not usually confused with any other slide. Prostate gland slide can be slightly confused with the slide of a mammary gland because they are also having the same kind of epithelium. And then we have what you see, the lumen to be seen like this in between. So one thing to note here that we have the smooth muscle to be noticed around these acinus. And number two, the second thing, I'm sure that if they give an image-based question on the prostate gland, they will make sure that they will show these prostatic concretions also in this calcified product will be seen in the lumen of the acinus. So this is a quick recap on the slides of the GIT. This GIT, we're done with that respiratory and now this urogenital system as well.